Good morning and welcome to the Integrated Care Board meeting in public on the 5th of January 2023. So firstly, Happy New Year to everyone. I think most people I haven't seen before today, so Happy New Year. And I hope it is a fruitful year for everybody in the room and obviously people on the screen also. And that we all remain wealthy through it as well and start seeing some green lights to the things that we're trying to achieve. So thank you for coming, welcome, and let's proceed. So we do have apologies. We've got apologies from Sam Crowe, Director of Public Health, Graham Farrant, Chief Exec of Bournemouth Christchurch and Poole Council, Spencer Flower, who's the local authority partner member, and Drew Meller, but we do have, I think, Karen Rampton here in place of... Hi, Karen. Good morning and lovely to see you. And then we've also got apologies from Lisa Harwood, who is not well today. So I think other than that, we're expecting to see everybody else here.
Yeah, we're just waiting for Dean.
I noticed Manisha's not here. Has he sent apologies? No, okay. So we're waiting for Sean. So I think there's a few people that aren't here. But and then we are going to have some people joining us. So we're going to have Fran Pingarelli, Sarah Smith. Welcome back, Sarah. I know this is one of your Keep in Touch days. Lovely to see you. Francis Avis for the patient story, and also Kirsty Hellier for the patient story. And Karen, we weren't sure if you were joining us, but I can see you on the screen, so welcome. And then in the room we have Suzanne Payne from Pfizer, so welcome, Suzanne. And then we have other people from the public joining us on screen, and I won't go through the names now, but and I'm not sure most of them are on actually, but there should be others joining us on the screen. Looking around, I think we're quorate, and I'm if I nod from Liz to go from there. Can I just check if there are any declarations of interest before we proceed? No. So if anything comes up while we're going through, please make sure that we can declare it for the record. So I'm going to go to the minutes of the last meeting, which was on the 3rd of November, and I'm going to turn the page. So if we can go on page 1. And this is just for any matters of accuracy. Page 2, page 3, page 4, page 5, page 6, page 7, and page 8. So I will take silence as being an accurate record. And then the action log, I think on the action log, people would have seen it beforehand, but on the action log you will see that everything is either complete or in hand, so there's nothing that we need to pick up today. So thank you very much for that, Liz. So without further ado, welcome Siobhan and Manish, and Happy New Year to both of you.
Sorry.
Oh no, it's not a problem. So Patricia, I'm going to hand over to you for your Chief Exec report.
Thank you. So I'm only going to pick up a few highlights and then I'm happy to take any questions. I'll just assume that the report's been read. There he is. Sorry, we're in a bit of an operational mire and I was a bit worried that Dean hadn't arrived yet.
Oh, apologies. Right,
that's why
sorry.
I sort of hesitated.
Yeah, sorry, thank you. That's why Liz is here, because she knows I'm going to make a mistake. Sorry, we're meant to be doing the patient story first, so I'm handing over to, is it Dawn that's going to introduce it? Thank you very much, Dawn.
Thanks, Jane. Good morning, everyone. So today's video shares with you the experiences of 3 members of our community have had using our services. And the experiences that you'll hear are examples of what have now become priorities within the Integrated Care Partnership strategy. The next stage is about co-designing the solutions to deliver on those priorities. And once you've watched the video, we have joining us to take your comments and your questions about those next steps. We have Kirsty Hillier, our Deputy Director of Communications and Engagement for the ICB, and also Francis Avis, who has brilliantly led on some of this work. And thank you to Keith for the video production.
You know, my route to getting support when I need it is it's first and foremost friends and family, and then if I get to the point where I need kind of more of a medical intervention, I generally self-refer to Steps to Wellbeing and kind of go through the CBT process. Yeah, I mean, it's this. I imagine this is something that you'll hear over and over again, but I find that the health system here is kind of full of amazing people doing amazing things. There's just not enough of them. And so you, instead of being in a position where you're able to go, you know, I've been here before, so I know what works really well for me, and I think this is what I need. You kind of still have to go through the whole process of, you know, that's been set up, and kind of transition and do your sort of 6-week CBT, which is really challenging when you've done that multiple times before, and then kind of come out the other end and hope that what might happen is that they might suggest you get the treatment that you feel that would be helpful. You know, everybody's kind of funneled into a process, and so you feel like you're in a sort of tick box exercise instead of really being able to kind of work through what you're going through.
Which I found a bit difficult with, you have to phone 111, they talk to you, then you phone your doctor, they talk to you. I did tend to get bounced backwards and forwards once. This was after a skiing trip. I had a fall, and I thought I'd probably cracked a rib. I had it at my shoulder and wanted to get some attention. It was literally on the way back from the airport. We were calling on a journey on the way back, and we seemed to be forever being told to phone this number. So that was not the best of experiences, because I just wanted somebody to look at me. Weymouth Hospital were telling us to phone the Dorset Hospital. The Dorset Hospital were then telling us to phone the Weymouth Hospital. I said, well, we've just phoned the Weymouth Hospital. I just want somebody to have a look.
I think, so for me, as a woman living with HIV, it feels like quite often anybody living with HIV, they're not heard. It's like those stories aren't shared, or it's always associated to like some sort of risky lifestyle or something. So it feels that we're left behind in conversations. I think something that was, you know, my work colleague brought up about that, you know, how do we fit into boxes? Because we don't. You know, not everybody always automatically fits into a box. We know there's a criteria, but for people living with HIV, I think sometimes you have to make those lines on that box like a little bit invisible. Yeah. Or, you know, when people look like you read a letter, or you read something and they say, oh, you need to read between the lines.
Yeah.
That for me is what maybe social care or social prescribing that we talked about, you know, earlier. You know, don't look at a box and think, well, you know, they don't tick that box, so I can't take them any further. Yeah. Actually, look at that box, take the lines away, look at us as a person, not HIV, and you'll see that actually we tick that box over 1,000 times and we meet your criteria. It's just not something you're used to dealing with.
So happy to open up to any comments and questions, and we'll bring Kirsty and Francis in as needed.
Thank you. And thanks for pulling that video together, actually. So are there any comments or questions for the team? Forbes.
Okay, thank you very much. It's helpful. I think that, I mean, all these stories resonate, don't they? The first one is we need to know more about why the lady keeps needing CBT. You know, because you want to actually move people into a sort of state of well-being and wellness and able to sustain themselves. But the more point was about the second man's story. We're hearing a lot of that at the moment, aren't they? About people getting, you know, it's very difficult to access the system. And I know people in this room have shared their own, you know, comments about their own experience or their family's experience about how difficult it can be to access the system. And I think as an ICB, we could be better than we are. Despite the demand that we have, we could signpost people better at the first point of contact, rather than, quite frankly, the perception is everyone's very busy and they're just trying to move you on to somebody else as quickly as you can because we don't really have time to address your need.
Okay, thanks, Forbes. I do want to come back to that at the end, actually, because I think that's the key point for me. But Kay and then John.
I just wondered if there was anything that really surprised or shocked you in the conversations that you hadn't known about before, or did it reinforce things that you already sensed were issues that needed to be dealt with?
And I'm going to bring Francis in at that point, and hear what Francis got to say about that.
Thank you so much, and thanks, Kay, for a great question. I think just taking one step back from that, the reason we embrace this methodology was that we've done so many surveys with this particular group, you know, to inform strategy, and we wanted to adopt a methodology that would help us to reach people we didn't normally reach and to listen to people in a different way, and that certainly happened. I mean, the depth and the richness of the stories that we heard, that we are still hearing, has been absolutely fantastic. I think the themes that have come from the stories are not necessarily unexpected, and that probably reinforces our direction of travel, which is a positive thing. But within that, there are golden nuggets, if you like, of other things that we're picking up across the way that Kirsty and I are kind of identifying and pulling out that we wouldn't necessarily have heard before, which we'll obviously share with you as we identify them. And the other really exciting thing is that we're now embarking on plans to scale this up at neighbourhood level, working with the academic health network and population health management people to help us really delve deeply into the data so that we can analyse it really effectively.
Okay, John and then Debbie.
First of all, I wanted to say thank you. I think actually hearing firsthand the authenticity of it's unfiltered. It's, you know, hearing authentically what it's like is so important, and it's really impactful because of that. So I think that was the first comment, and it probably speaks to the first theme that I think I heard, which was around personalisation. And I think there is this, I suspect that one of the themes is that there are people and then there is the system, and somehow there seems to be a buffer between the two, and it's about how does a person navigate the system and how do we help do that. And I sense from this piece of work we can probably learn about how do you help an individual navigate the system. And many people in the ICB will know about this system and this environment, but it's quite hard if you're just a person in this region dealing with something and want to know how to get through. So I really heard, I think that personalisation came through, and I think we really need to hold on to that. But access just felt one of the issues. And I used to work for BT, and we used to talk about the BT shunt. You used to ring up and you'd say, I'm not the person that you need, and then you get shunted to somebody else. And I think we were hearing examples about the shunt, and I'm thoughtful about how do we put this personalisation at the front end so that no matter what the issue is that somebody's ringing about, we can help them navigate through this system, because the person who is speaking to them and receiving the call has probably got a better ability to be able to help through the organisation and how to get them the point of care they needed. So those were just two reflections, but I really found it impactful, and I thank you for making it so authentic.
Thank you, Debbie.
Thank you. Yeah, I totally support what everyone has said. I think it's really, really helpful to hear it from, firsthand from patients' real experience and our population's experience. I think for me, it's just a question around how we now take that feedback into action to actually do something, because the access issues isn't something new, is it? It's something we're fully aware of, and it sort of it's just supported by this. Oh, sorry, can you not hear?
Oh, okay.
So can you not hear me at all? There is a microphone there.
Yeah, it's probably that one there. Just take it off the top of the.
Oh, okay. Take it off the top.
Sorry. So my question was really around to the team, really. How are we going to take this feedback into sort of action to actually make a difference? And how can we, as a board and an executive team, sort of support that to happen, really? Because so the issue around bouncing around is all of our responsibilities, and we're not going to deliver it with just one of us, are we? It's got to be sort of worked across the systems. So that's my question, really. Really thought it was invaluable, but just want to know sort of next steps, really, and how we take it forward into, so that we're not listening to 100 voices a year down the road and it's exactly the same.
Yeah. And that was the conversation I wanted to get to on the back of what Forbes said. So can I suggest we pick that up towards the end when we've got other comments? So Dan, you're next, and then I've got Karen and then Paul.
Thanks. It's a similar point to Debbie's, but kind of a step before. So I wanted to ask the team, have we or will we or how can we go back to the 100 and say, thanks very much? Not that we fix the issue, which you definitely want to do, but this is how we can show you how those themes have come through in the ICP strategy. It's really powerful to only have 100 people who've said, well, we were really listened to and influenced the strategy. And I just wondered if we thought about closing that feedback loop to say to the 100 or a population of the 100, thanks very much, because you said this, you can see this here. And I just wondered if we thought about doing that, and if so, how we're going to do it. Thank you.
And if the team want to pick that up now, or do you want to pick that up with this so what when we get there?
I think let's hear the
That's
other
fine.
questions. Yeah.
Okay, and then Karen and then Paul.
Thank you. The two previous speakers have picked up my first 2 points, so that's great. We're all kind of very much on the same page. But what I wanted to just say was how much it struck me that these priorities, a lot of these priorities aren't necessarily medical based priorities. They're not maybe clinical solutions, but are actually embedded in the community. And it's how we then respond to that as a system, which I think is truly important. Anyone that listens to me, I'm banging on about prevention a lot, but it's important, I think, that we embed our solutions within our communities. We're working together on it. So that was my comment and observation.
Thanks very much.
Thank you.
Thank you, Paul.
I think there's a balance, and it's a really challenging one for us to do as an ICB, because I can completely understand that we put in place quite rigid pathways because we have to do something about managing demand, because we've only got a certain amount of capacity, and it's our way of coping to match that capacity demand gap. What we hear here is how that feels for some people for whom that rigid pathway doesn't fit, and I think the personalised approach is really valuable, but if we did personalised approach from everyone, then it would be really challenging for us to keep pathways running in a way that was smooth and used our resources best we can. So where's that balance? And we've got to strike it. There's got to be enough flexibility for those exceptions to be genuinely seen as exceptions, but enough of a robust pathway that we can predict and manage the demand and manage it in the right places. So it's not medical when it doesn't need to be medical. It's not a doctor when it doesn't need to be a doctor, or a pharmacist, or so on. And I think that's going to be really challenging, because it's very easy for us when we see numbers to put in a rigid process to manage those numbers. But hearing this helps us know that actually there's two sides to that. But I don't think it's going all the way the other way. I think there has to be somewhere in the middle that we've got to find. Otherwise, we just haven't got the resources to be able to do it.
Cecilia.
Just to add to that point, Paul, what I was getting from the last person who was speaking is that she was caught somewhere between the medical and the social, and not really quite clear what her pathway should be. And I do accept the fact that we can't personalise everything for everybody. I think that's unrealistic. But if people feel that they're somehow not, they're between the lines, is how she described it, and that must be something that perhaps, as for the first patient, the expert patient knew what she felt she needed. She'd been through the process many times. And whether that's where we start to flex those systems by using those expert patients as part of that pathway. Again, not trying to find a solution, but listening to those different. The first one, expert patient. The last one, not quite sure how she fits in. Once she finds out where she fits in, how does she use that agency to make sure that next time she's in the system that she can really push it forward? Because she sounded like she wanted social care, she wanted community care, not health care, and was finding it, she couldn't find her way through that one either. Yeah.
Rob?
So I think it's a really difficult balance, isn't it? Because you're in danger of sacrificing outcomes for efficiencies just to help us manage the demand for us, as opposed to what people want. All of this feedback really feels like it plays into that place, community, neighbourhood conversation for what we're hearing. That's what people really want, and I know that we're setting ourselves up around that. And it comes back to this kind of like, I don't know whether you want to call it this as subsidiarity or not, but it's what needs to be done locally for these people versus what is done at an efficient access point. But generally, even if you have that efficient access point, you're going to drop it down into a local service at the end of the day, somebody turning up locally. So for me, this feedback is something that will help us, I think, a lot in the development of what we need to do at places.
Thanks. So first of all, again, I'll echo, thank you very much for this. I think we've said before how powerful this is, 100 conversations generally, and the patient stories more broadly as well. And for me, from this, a sort of a lot of what I was thinking has already been said, so I'll try not to repeat too much. But three big things that came out for me. The first is I agree with Forbes that there was something in that lady's story about whether when we're providing a course of treatment, therapy, whatever it might be, are we getting them to the right point, or are we in a rush to get people discharged and out of care, and therefore actually that creates that revolving door that we're all familiar with, and how do we do that better? Secondly, I agree with Paul that there are good reasons for having the patient journey planned in a certain way, because resources are finite, and not everyone can do everything. So you've got to make sure that people get to the right place to get the care that they need. At the same time, people outside the organisation don't always understand and can't be expected to understand what the correct point of access is. So they are going to go to whatever is the closest, most convenient, easiest place. So it's how do we either provide whatever care they need initially at that point, and there's a bit of flexibility there, or it's how do we, as has been said, facilitate their journey to wherever they need to be. And maybe there's something in there about flexibility, navigational mentoring, if you want to call it that, and also a bit of communication about, well, what is the appropriate path and where do you go? Because actually, I'm going to say this, aren't I, because I'm biased, because I'm a GP, but often that navigational mentor ends up being the GP, because people think, well, you know what, I can't make head or tail of this system, maybe my GP can help, and Forbes will recognise that often as the GP you end up in the same position and you've got no idea how to go. So if we can't do it, well, the public certainly aren't going to be able to navigate those systems. So I think there's something about making that clearer for the public, but also for our own staff. And the third thing, and I think I've said this before, and Dan sort of alluded to it as well, conversation is a two-way thing. And I get that the 100 conversations thing is a phased thing, and you know, initially it was about getting the information from people and finding out what they're thinking and all of that. But I think we need to move to that further bit of the conversation. It does need to be a two-way thing, because you know what, there's only one thing more frustrating than not getting an opportunity to make your feelings heard, and that's making your feelings heard but then feeling like you're not actually being heard. So we need to make that clear that, okay, you've said all of this, we've taken that on board, that here's what we've heard, because what's said, what's heard and what's understood and remembered can be different in conversation, so let's check that, and then ensure people that we are hearing what you're saying, and this is how we're responding to it.
Thank you, Manish. I'm going to go to Matt, and then I'm going to sum up and come back to you, Dawn, and the team.
Just want to check the microphone on the desk. This desk might be trying from the back seat. I thought it was really good conversation, really brave. It's not easy sometimes listening to somebody telling you that your organisational system that you're proud of and you work in every day is perhaps not working in the best way. But I think it's really important that we do listen to those. A little bit like a couple of the last speakers, I'm just picking up on how does it feel for staff? The other side to that, the other piece for that. You know, no leadership book ever said don't listen to your frontline staff because they haven't got a clue about how to solve many of the problems that we will collectively in a room of leaders try and solve, and actually not really necessarily solve it. So I guess there's the flip side to it. Where's the conversation with colleagues inside going, actually, how does it feel when you have to shunt somebody around, or when they get to you and they're in the wrong place? And I think the last contributor speaker, sorry I didn't catch the name, you know, that piece around looking at the wider system, how did they arrive at the NHS's door, and was that the right place for them to arrive at anyway? You know, so there's that conversation around the wider system, around social care, around other issues. How do we pick that up as well to make sure we're making the difference we want in the communities here? You know, data's great, but only if we do something with it. And I guess that would be my last piece, that last challenge. I think, Jenny, you're going to pick that up. You know, what do we now do with this? Yeah. Because it's been impactful to listen to that. But if that's the only impact, then it hasn't made any positive change. Then that's not good. And my final challenge piece was to think that 40 years on, we've still got some educating to around things like HIV. I found that quite challenging. Really, that people in this day and age would still think, you know, about that perception that HIV is necessarily from you know, promiscuous or risky lifestyles, when actually there's so much more data and knowledge and information and understanding. So that actually shocked me a little bit, really. So there's still work to go.
Yeah. Thank you. Who, sorry? On the screen? Yeah. All right, sorry. Karen, I'll take you as the last one. So I didn't see your hand.
Did you say Karen?
Yes.
Thank you. Yeah, just an observation, and we'll all be aware of this, but it seems to be an increasingly common narrative on social media and the press and so on. The health and social care system is broken. It can't be fixed. And then it turns into this sort of political conversation. And I'm certainly getting a lot of, not just my residents, but a lot of other councillors getting in touch saying, you know, what we're going to do, it's dreadful, it can't be fixed, blah, 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 blah. And I just feel that there's a lot of confidence from the person in the street who perhaps doesn't know and gets frustrated about not knowing how to access the care and support that they need. And I just think on a very, very local level, we also need to kind of tell people where it works, because it does work really well in plenty of areas. We need to tell people how it works and why it works, and we need to keep having that conversation with people, because this conversation about, oh, it's broken, I can't see a GP for 3 weeks, and I can't, you know, a lot of the time it's just hearsay. It's something they picked up in the paper and they're reiterating it. So there needs to be far more positivity, as Louisa said, plenty of signposting, flexible, plenty of clear information on a very local level. And we need to just keep doing that, otherwise this is just going to grow and grow, and the discontent is going to increase, in my opinion. And we need to get that information out on our Facebook channels. You know, all of us as partners need to be doing that. and giving examples of where it's worked and maybe even where it hasn't worked. However, this is what happened and it turned around. So I just wanted to make that observation that my inbox is becoming increasingly full with people who are becoming frustrated, and some of it isn't entirely accurate. Thank you.
Thanks, Karen. Neil, and you really will be the last one.
I don't think it's a resource issue. That person who phoned about his shoulder is one of hundreds of people who phoned that day, that week, and had to speak to 5 or 6 people when they should have spoken to one person. So when we get this right, we will free up resources. It's ridiculous that busy clinicians and busy people on the front line are taking phone calls to shunt people around, and we need to take ownership of this. We need a single point of access for all the services, and we are responsible for guiding people to the right place, not helping them get there. That will free up resource, it will free up time, it will improve the experience. And I think it'll help us take control of the issue of people using the wrong services, because that's our fault, not their fault. And witness the risk we've all felt that we could be talking about this in a year. So I'm quite happy to take ownership from a transformation point of view and come back to this board with proposals that within a year we will be seeing a very different video, because we will have solved this problem.
That's right. I mean, that's a really powerful last contribution to come up with. So thank you very much for that, because for me, I think that the crux of the issue stemmed from Kay's question, which was, were there any surprises? And essentially what you were saying is no. So delving down into more data for me is not the issue. It's what do we do? We know it's an issue, so what do we do? So thank you for that, Neil. And then the second thing was to pick up on Debbie's point about the so what, because actually if we're going out and speaking to people and then we're not acting or ensuring that things change, then I would say what's the point of doing that, because we're raising expectations when we aren't going to do anything about it. So I think there were some themes that came out, but one of the themes that Dawn, you and the team and Patricia might want to pick up when you come back in, is the thing around access. So how do we, I liked that single point of contact, because I think that might be the way to solve it. But I think there is also something about empowering our workforce, because I think often it's also because the workforce across the system doesn't really know. So rather than saying something and probably getting it wrong, they probably say, oh, no, you need to call this or you need to call that. So how do we empower our workforce either to make some right decisions or to access the information that they can then pass on, so that we aren't necessarily providing a patient centred service, but it feels like that to the patient? Because I'm sure we've all been in situations where you call a customer service line and the thing that you remember are the people that go out of their way to help you. Whether or not they've got the information, they will go out of their way to help you, and that's the thing that you remember. And I saw a drama over the Christmas break, actually, which not really relevant to what we're doing here, but it was about a single parent moving from one end of the country to another, and then being unable to access anything, benefits, etc., etc. And there was just this downward spiral. And what you saw, it was done as a kind of docudrama, but what you saw was this individual speaking to faceless individuals who were not at all interested in her and her situation. And I sat there thinking, God, I hope we don't have services like that in Dorset. I really want our system to be one where people feel that if they access any of our public services, that they feel that people are actually treating them as individuals. So I would want that to be one of the points that we pick up on. And then the last two things for me was one around pathways. So one of the powerful things about the data is that it might exemplify pathways where there are consistent issues. So then let's focus on those pathways and get those sorted out. And then the very last point was to pick up on a point that I think both Matt and Karen made, which is and Manish, which is the comms. I think there is something about making sure that we can get the comms out where things are working well, and that needs to go out across the system so that everybody's working from the same information, but also being honest where things aren't working well and then what we're going to do to fix that. So a number of things. Do you want me to go to, do you want to come in first and then we go? Yeah.
So we have got a workforce issue in the NHS, there's no doubt about that. I don't actually believe we have got a funding issue. think we just don't use our resources very efficiently.
Well, yeah.
And I don't think we do our case any positive favour with government when we're constantly talking about the NHS needing more money when we can't demonstrate that what we do is efficient. So I don't actually accept we've got a funding issue unless we start to work at the optimum, and then we can absolutely demonstrate that. I think what this comes down to is the fact that our systems are too complicated, and that starts at the centre where every initiative we have is not about redesigning service models end to end, it's about layering on different solutions to different ends of the pathway, and it just makes it more complicated. So I've no doubt that we've probably got 50 plus entrance and exit points to our urgent emergency care service. Ridiculous. I can't navigate my way around 50 or 60, so there's no way a patient can do it. So I think one of our tasks when we start to do the transformation programme next year is to redesign our service models and simplify them because they're too complicated. I think one of the other issues we've got is that we can quite easily medicalise a problem that is social, and we've got to get out of the habit of doing that. Karen Loftus and I were talking yesterday about how many times patients find themselves in CBT when actually their issue is not their anxiety. Their anxiety has been driven by low income, poor housing, and we actually need to solve that rather than getting them into some sort of counselling service, because all they do is go back into the same situation they were in before. So a lot of this comes down to how we work as a system going forward, and particularly how we work at place, that integrates our services, that simplifies the pathways and leads to a more person-centred approach rather than what we've got now, which is a process-centred approach, which is quite often driven by organising services how clinical teams need and like to work as opposed to how people need to receive service. So that we've got to start to get into some middle ground there around what our communities actually need. For me, I would really ask our partners to really think about embedding this approach that we've taken with the 100 voices properly, because if we don't do that, we're not able to show that we're listening, we're not able to understand lived experience truly, and we're not able then to properly co-design services around individual needs. And we're great at doing consultation, we're great at talking to patients when we've already formed a document or review, but that's not co-design, and that's not building services around their needs. So we need to think really carefully at an organisational level how we're going to embed this type of working as a given. Around the strategy, Sam and Kirsty are developing a public-facing, much briefer document to be shared with those 100 people that have engaged with us around this process, because we've been very careful to show a golden thread in the document around what they said and how it's now been translated into a strategic ambition. And as Francis said earlier on, the next piece is how do we broaden that type of engagement to a much wider group of our community to really start to co-design some of the solutions in the transformation programme that Neil will be leading. And then I think we've got work to do in terms of the relationship with the wider partnership at place, which David is picking up in terms of at least managing or establishing the leadership and governance framework for that with PwC before we then get into the delivery and the development of service models at place, which will start to look at, yes, health issues, but more importantly focus on the wider determinant issues which need to be addressed further upstream to help people get into a place of living a healthier, more productive life.
Thanks,
but it's all in our gift.
Yeah. So Neil's offered to pick up the transformation as part of the transformation
yeah,
piece.
Neil's leading on that.
David's doing the place. Is there anything else from this that needs to come in?
Neil and I have talked about the fact that when we get onto my report, which is out of date now because it was written a month ago, the planning guidance actually was produced on the 23rd of December. Nothing like getting early warning.
It's always a Christmas present.
I know. because it was produced so late, the timetable for submitting the forward plan has now moved to June. What I'm going to ask the board to agree to is that we don't adhere to that timetable, that we still work towards getting our forward plan finished in March, because we need to then step off on the 1st of April around the transformation programme. Neil's leading on that, so when we come back to board development early February, we'll start to share some headlines around that and some potential savings that sit underneath it to really socialise that with everyone and get everyone's views.
Okay, thank you. So, Dawn, anything else that you and the team want to
I
say?
think Patricia sums up next steps really well. What you've seen today is the output of the first phase of the people and communities approach. It's the start. We've raised expectations. We now need to deliver on those expectations.
Yeah.
Thank you.
And the only other thing I would say is not to breach Kirsty's confidence, but Kirsty's actually got quite a difficult situation at home at the moment, and because she is so committed to this programme, she chose to attend the board today.
Well, can I thank you, Kirsty, for doing that. I know you've been working really hard with us up to the setup of the ICB and beyond, so thank you for that personal commitment as well. And if it helps you now to log off and get back to what you need to do, please do that. Right, thank you. Thank you very much. And I think that takes us on to the right order now, which is your Chief Exec report.
So, I don't apologise for the length of the report, because there is so much going on in the health and care sector at the moment. It is proving impossible to get the report down to 6 pages, and we've still put a lot of the positive feedback around our partners into an appendix. So the really important things that we need to just pay attention to are, first of all, you'll see that Steve Barclay has been reappointed as the Secretary of State for Health and Social Care, and Jenny and I had a meeting with him before Christmas with the intention of some partnership building, some fact finding around the value of ICSs on his behalf, and his team evaluating where ICSs are 6 months in to their establishment. What he also said was that the first floor of the Department of Health offices are now available for hot desking by health colleagues, with the intention of trying to bring the delivery closer to Permanent Secretary and Ministers. So I haven't taken up that offer as yet. But
I was about to take it up yesterday, but train strike meant I couldn't.
Yeah, well, that is available to us, and that's an attempt to try and get closer to the front line. So the meeting was really positive. I just need to draft a note back to him now on a couple of things he wanted some more information on around changes we might want to seek around GP and dental contracts, and roles that we might want to be considered as pilot sites for development that don't require undergraduate degree education to be able to do them. As a consequence of his appointment, he has, Patricia Hewitt, Rob Webster and I were invited to give evidence to the Health Select Committee on ICSs in November. That committee was looking at autonomy, accountability, and how national targets then reflected on locally driven community priorities. As a consequence of that Health Select Committee meeting, Patricia Hewitt was then asked by Steve Barclay to do a national review on how we reduce the number of national targets in favour of more locally driven priorities and strengthen the responsibility and accountability of ICSs. So I'm sat on the review group with Patricia Hewitt as the chair. We have submitted the first set of findings to the Secretary of State just before Christmas. We are now targeted with producing the final set of recommendations by the end of February, early March, and we've got 5 subgroups that sit underneath that review panel, and I'm chairing the one that looks at population health and prevention, which starts next week. So I'm really confident that what we'll get in the next set of planning guidance from 24-25 is a significant reduction in national targets and more local autonomy. And the reason why I'm quite confident in that is because Steve Barclay's commissioned Patricia Hewitt directly to do the review without any involvement or very little involvement from NHS England. So I think that's a positive. Other things that you need to pay attention to, obviously you'll see that we've got we've had one date of industrial action already in December, which was the ambulance service. We're going to see further dates from the ambulance service later this month, and we've also been identified now our 3 Dorset health providers as locations for industrial action for nurses on the 18th and 19th of January. So we didn't see the impact that we thought we would see in terms of the ambulance strike. I think for the control centre, and which is based here, and our partner organisations managed that pretty well on that day, although it was fairly stressful for everyone having to keep the control centre open until midnight. And the day after proved to be more difficult. And we have had a number of days over the last few weeks where safety has been compromised. We are now onboarding in our wards, which means taking in more patients for admission than the ward can actually hold safely. And we've had patients bedded in our emergency departments for over 3 days waiting for a bed. That is not where we want to be. So we've got challenges across the system which are mirrored across the country. I would have to say that 3/4 of NHS providers have been onboarding for quite a while, so ours are the last ones. But that's not a place we want to be in. So we've got work to do to get people out of hospital more quickly, but also support our social care colleagues to provide the right level of care and support outside of hospital so that we're preventing unnecessary admissions. So to say that we're a bit concerned about the 18th and 19th, I think is probably an understatement. The Secretary of State has announced a 500 million adult social care fund to be divided between local authorities this year. It comes in 2 tranches. It will be recurrent for 2 years, but that is dependent on whether they see a reduction in no criteria to reside before they make the decision about whether that funding will be recurrent. We've had fantastic cooperation from local government colleagues in deciding how the money allocated to Dorset will be spent. We've now got 60 extra short stay reablement beds in BCP area and 30 in Dorset Council area. We've still got more work to do in terms of moving forward with things like discharge to assess, but we're making good progress, but it is not having the impact that we'd really want it to because of the level of demand that we're dealing with. So we need to work really hard in the coming year to try and stabilise the capacity and demand issue that we've got, because only then will we start to see the cost of care coming down, because we know the research shows on average the average cost of care for individuals is not rising because their needs are changing, it's rising because we're not getting to them fast enough. We've been through health and social care. Then we've got we've almost finished the operating model for the ICB. We've involved lots of partners in that conversation. We'll be bringing something forward in the next few weeks for the board to sign off. We've tried, having looked at other ICB operating models, which quite frankly were so many pages I lost the will to live at about page 25. I'm so glad that Dean has simplified ours into not just that it's not complicated, but also that it's written in really simple language as well, so our staff will understand how to navigate their way around the decision making process. And I said we'll bring that to board for a discussion and approval. The next step is to involve the wider partners in the operating model for the ICS, which I don't think will be much different than what we've got for the ICB, but just to be really clear about how decisions will be made across the wider system. I've talked about the multi-year plan and we're on track with that, and when we get into part 2 you'll understand how the implications for what will be in that draft, and we'll share that again at the board development session early next month, what the implications will be then for what we decide on how we want to manage our finances this year and next year. We held a GP summit a few weeks ago that was organised and chaired by Paul and Forbes, so thank you to them for that, and David. I think we had a really good conversation for most of the day around what we need to do to work together to not just stabilise primary care, but also relieve some of the pressures to improve work-life balance and develop a longer-term strategy. We have reached an agreement on how we might manage some of the enhanced service reporting going forward up until the end of March. That's been quite a difficult conversation with regional and national colleagues who were really supportive of the direction, but conscious that they also didn't want us to write anything that contravened the Health and Care Act. So we work hard on a form of words that doesn't change the direction and action, but does make it clear that we're still sitting within the legislation. We have a meeting in the diary scheduled in a couple of weeks with Amanda Doyle, who's the National Clinical Director for Primary Care, to have a broader conversation about the primary care contracts for GPs and dental, and where the direction of travel needs to go in order to make the contracts workable for GPs, so that they can spend the majority of their time on the things that they want to and need to, which is looking after patients. So we've worked hard on what the shared agenda might be for that meeting, the things we want to raise with Amanda. And Steve Barclay encouraged us to also meet with Neil O'Brien, who is the National Minister, the Minister at the Department of Health, for primary care contracts, so we can follow that conversation up with him as well. So I think that's a positive. And we've got a follow-up workshop in the next few weeks to talk about some of the longer-term issues. And then I thought it would be helpful just to just note a couple of positive things about our partner organisations. So for DCH, they have in September achieved accreditation, national accreditation for quality for the anaesthetic department for the second time running. There's not many departments in the NHS that have achieved that, so that's a real positive. Inpatient survey results were really good, despite the challenges that everyone has around accessing service. For our GP Alliance, you know that formed in July, and Forbes has been elected as chair of that. I think that's a really positive move, and we can start to see some really positive things coming out of that relationship. Dorset Healthcare and DCH have now appointed a joint chair, which is Matthew Bryant, who is currently the Chief Operating Officer at Somerset Trust. That's a really positive move. Matthew has lots of experience in the work that he'll need to do in bringing the clinical model together, and he's a very strong values-based leader, so I think we're going to be really fortunate to have Matthew leading that process. We've also Dorset Healthcare and the Avon and Wiltshire Partnership have also been jointly awarded the contract to provide mental health services for armed forces, and again I think that's a really positive step. I don't think you'll be surprised to know how many of our former armed forces colleagues end up being treated by the health bus, which deals with people who are homeless, so we've got work to do from a social perspective in supporting them to get back to civil life in a productive way. South West Ambulance Services have appointed a new chair and also a couple of new substantive executive directors, which again I think gives Will a really strong team to move forward with, as we will move into the lead commissioner arrangement as we go forward into the new financial year. And they've also been we've also noted that they have a new practice educator course, which is being used as a national standard for the paramedic profession, so I think that's a really good step for them, and it brings some positive light to SWAST in what have been some of the darkest days over the last few months. UHD about to embark on Patient First as an initiative to not just improve safety but quality improvement and culture. So we'll be watching that, see what it produces, and then have a broader conversation about whether that's the right thing to embark on across the entire trust. The new hospitals development at UHD is going really well. Pathology will be complete by April, and Siobhan's pushing really hard for the other bigger build to be completed by 2024. In terms of our local government colleagues, BCP, really good work in terms of the cost of living resilience, which is really relevant for this moment in time. And the work on the Vibrant Communities Board is really starting to get into the meat of asset-based work in generation and building on strengths of communities, which is where we want to be in the long term. And then finally, for Dorset Council, the move to Care Dorset, that's been absolutely pivotal in creating the extra 30 beds, and really, really pleased to see all the improvements in children's services and children's social care, which have been absolutely fantastic in taking those services from inadequate to good, and we're starting to see some real traction underneath them. So, you know, our biggest risk right now is how we get through the rest of winter as safely as we can. We're not in the peak of winter yet. We still have some irons in the fire around changing the way we might operate, particularly in terms of the coordination centre. Yeah, we all keep our fingers crossed, apart from the actions that we're putting in place, that things don't get considerably worse.
Thank you, Patricia. Can I just add 3 things before I go for questions and comments? So the first one was around the meeting with Stephen Barclay, and as Patricia says, we both intend to take up the offer of hot desking on the first floor of DH. As I said, slightly in jest, but in reality I was actually due to be there yesterday in London, and I had scheduled myself to be there on the first floor, but had to cancel that because of the train strikes, so we will do that. And I think it's a real opportunity for us actually just to develop those informal relationships. The second thing was on the planning guidance, and it's you know, it's traditional for it to come out well, Christmas Eve, so we had it day before because Christmas Eve was on a Saturday. Just personal disappointment for me with the planning guidance that there is almost no reference this year to workforce, and I just really struggled with that when we know that's kind of what, like, our number one big risk at the moment. I couldn't quite understand how that's come out of NHS England. I have kind of lobbied a few people because obviously that's the area I was working in before, to try and understand that. And because of that, there's also very little reference to EDI in there. So I was quite disappointed by it. But so I just wanted to note that. And then the last thing was just to pick up on the comment that you made about ED and the current struggles. We know that a member of the ICB at the moment, father was blue lighted to hospital last night, 90 years old, few health issues, Alzheimer's, and spent the night on a trolley in one of our hospitals in a corridor. So, and you kind of think if somebody of that age and needs spent a night in a hospital corridor, then that's, you know, that's a real example of how difficult our systems are at the moment. So yeah, so anything we can do to kind of keep making the moves forward that we're doing will be appreciated.
I think I've got some update actually on the workforce stuff.
Have you?
Yeah, so oh God, I've got too many things on the go at once. I'm in the National Reference Group for the Workforce Strategy, and the reason why it's not referred to in the document is because it's not finished. And it's not finished.
Talks about the strategy.
Yeah, it's not finished because it needs a lot more work. We still haven't got clarity about whether we need to get government approval for it, or it's just signalling a direction of travel, and it will need to be funded. So they've not published it as yet, because we need to understand whether there is going to be additional funding in order to support it. Because it's not a 1 or 2 year workforce strategy, it's a 15-year strategy, so it needs cross-party support. The ED&I work, I think they're going to publish something in the new financial year.
There's an EDI strategy,
because Terry's still working on
who's
the national lead, still working on the strategy, and it is very different than what we've had before. So
yeah, and
hopefully-
it's not to say the work isn't going on, but I just
Yeah.
think it's disappointing
It's
that
not even
with all of that
referred
grade,
to.
it's not even referred to, because people will then take their eye off the ball. So, and it was quite hard fought last year to get workforce in and to get it in as the number one thing to do. To not see it at all this year, I just thought was disappointing. So, okay, so open for questions and comments. Cecilia.
As a comment, I just think it's a fabulous amount of work that you're doing, and it's so good to see that you're actually involved with some of those national pieces as well. Again, it gives us all hope that there will be some change. So thank you for doing all of those things. I just had one question. On 3.4, you talk about direct GP access to tests. And I was just wondering what the
See what you've done now. See what you've done now.
Oh dear. I just wondering what the expected sort of impact on routine referrals has been with that additional potential possible burden that I was anticipating from that.
Do you want to comment on that, Probs?
Oh dear.
Well, actually, but I'll pass it to Ben, because we had exactly this conversation an hour ago this morning. So.
Over to you, Ben.
So
Has Ben got a mic?
I have actually, I think.
I think
I'll
you need
take
the
this
other
one.
one as
That's
well.
great. Thank you.
Yeah.
Well, no, it was just to pick up on. I wasn't quite clear as a primary care member as to what that access referred to, because I'm not sure that has actually materialised as yet. Although there is. So I suppose that was the question. I saw it in the report, but I wasn't quite clear what access that was referring to.
According to NHS England, you as GPs can now directly order CT scans, ultrasounds and brain MRIs.
But my understanding is that hasn't been actioned locally.
All right, okay. Well, we need to pick that up then. Dean?
There are some that GPs can already access. There are a few that you can't, and brain MRI is one of the ones where, because of the capacity that there is, that hasn't been opened up yet. But I know within the diagnostics teams, they're looking at how they can open these up over the coming weeks, just to look at kind of the capacity that we've got. But a lot that's already on the list is open for access already.
Maybe
but I
take
can talk to you
outside, but we'll
yeah.
talk outside, because actually outside of ultrasound, no direct access CT or MRI imaging is available to any primary care team. So.
Okay, so it sounded like a simple question, Cecilia, but there'll be more discussions going on.
Yeah, it's a good point.
Yeah.
We will take it outside, because we
Thank
do
you.
need to clarify this. Otherwise, we will create further, perhaps,
Yeah, exactly.
unrealistic expectation.
Yes, that we can't meet.
Yeah.
Okay, thank you. Any other, John?
You said it in jest at the beginning, but you were right that there's so much going on at the minute. To try and distill that in six pages is superb. But also the step back point is, my goodness, since I've been involved on the ICB from the 1st of July, it's always felt busy, and oh my goodness, there's a gravity to this which is long and sustained. And I think I noticed that the shift is moving much more towards local interventions, and I wanted to make the same point that Cecilia made, which is it's fabulous that with all of this going on, Dorset and you are finding, and Jenny, finding the time to be able to say this is a way through to actually drive us towards a set of much more local recommendations, if you like. And it's brilliant that with all this going on, we're prioritising the time. I think you're absolutely right to be working nationally and locally together. So that was the first piece. And I guess as part of that broader context, and you've referenced train strikes, but industrial action, I really hope it comes to a conclusion soon. But my sense is that it's going to add to this sustained pressure. And I know it's an obvious point, but whilst in the report it says we hope it comes to early conclusion, my sense is that it really won't. And therefore, knowing that we're thinking about how we manage through this over a sustained period and what that does to the organisation, the people of Dorset, etc., I'm sure you're on it, but it was just to add to the point that there was too much optimism bias in the closure of the industrial action position, I sense as written, but I know that we're attending to it. But those were just a couple of reflections.
Yeah, I mean, to be honest, I am worried about industrial action, but I'm more worried from a staffing perspective about moral injury. because the quality of care that people are able to provide at the moment is nowhere near what their expectations would have been. I wouldn't want to, Andrew's here, I wouldn't want to be a paramedic today. And we're going to have a lot of mental well-being fallout when things start to improve.
And I think that's the point to emphasise, isn't it? Because when I speak to people about voting for strike action of workers, they're really clear it's about the moral injury that's going on now. This is not just about pay. It is about not being able to do the job properly that they have qualified to do. And if you have then a government who's refusing to even get in the room to have the discussions, then I agree with you, it looks like it's a long haul as opposed to a short haul. So, and that's only going to exacerbate how people are feeling, isn't it? So, did you want to come in at all on the paramedic stuff?
Just to say, just to echo partly of what you were saying on that, we have quite a lot of dissatisfaction within the workforce because they didn't do all that training to sit in the back of an ambulance for 12 hours and hand over one patient, and it's not the job a lot of them signed up for, and that leads to a lot of resignations and a lot of dissatisfaction. So it's a really important thing that we've got to address. And I think as the pressure eases, we're going to get more health issues in the workforce as a result of that. I think that people are doing their best to cope at the moment, but when the pressure eases, I think that we're going to see those issues coming back to light. Thanks.
Thank you, Andrew. Forbes.
Thank you. Just to support some of the comments. I think I think it's a really comprehensive report, and there is so much going on that you start to struggle to see the wood from the trees. I think it's really helpful you're involved in these national conversations, because I don't think nationally they're doing anything to help themselves at this point in time, either for our patients or for our staff.
I might get evicted soon, Forbes, when I keep saying things they don't want to hear.
They seem disconnected. I have to say, I think the government seems to be struggling to know what to do. I mean, there's a national conversation to be had about what the health and social care can offer for the country. They don't seem really willing to have that, so therefore their knee-jerk response is we'll throw more money at it, and actually what we need to do is throw more workforce at it, really, and that's the point that you've made, Patricia. But so therefore it goes back to what can we do locally, and I think the challenge here is to demonstrate that we're listening to our population and to our staff, and then try and influence change as much as we possibly can, and I think that's the trajectory that we're now on. This issue about meeting expectation but also managing expectation, and it links to the point about the single point of access and about the comms. We don't help ourselves sometimes. I'll use the recent Group A streptococcus scenario. So a system's already overwhelmed. We have this infection which is very prevalent but not necessarily worse than it's been before. But we create absolute fear and anxiety in our population because of, quite frankly, a paucity of national comms. You can't blame the patients, you can't blame the people. They read messages that says go. Then, of course, as practitioners, we are further overwhelmed by people. We've got huge pressure on us to prescribe more and more antibiotics, which suddenly run out, and you think, well, hang on, if this was kind of managed at source, it wouldn't remove everything, but it would help. And we just seem very deficient in that way. So anything we can do locally, a conversation outside of this room about how we manage our comms, and that would link to the single point of access and how people access the service would be, could be, I think, a very, very, very productive locally. So I would favour us working quite hard on that. Thank you.
Yeah. So I raised that with him because I think we would have had a completely different response if the Chief Medical Officer and the Secretary of State had stood up and said, like they did through COVID, and there's a whole lot of reasons why that didn't happen apparently, but that that doesn't help us. But the national work streams, it's trying to get the balance right between the time put into those as well as what needs to happen locally is getting more and more challenging. But part of the dichotomy in my head is, if you're not there in the room with that small number of people making decisions, are you going to end up with the right decision? And that's not because you don't trust colleagues, it's because people quite often take the path of least resistance. And the workforce one is a really interesting one in that there's a lot of data and analysis gone into a 15-year plan, but for me it's not fit for purpose yet because it doesn't address the digital improvements that will mean that we might need not as many clinicians as we've got now in some areas, because people are not thinking about 15 years in terms of the future, they're only thinking about 15 years in terms of the demand. DFE are really working really closely on this for the first time ever. It's not being seen as just a NHS workforce issue, it's been seen also by DFE as a growing your workforce issue. But again, we're not thinking broadly enough about what needs to change in the way that education is offered that encourages more people from deprived backgrounds to move into professional areas of work, because that requires a different approach that changes children's views from what they hear and know at home to what the possibilities are in terms of their intellect. And we're not even having that conversation because, again, we're seeing it through a very narrow lens like we always do. And you need more people from different backgrounds in those conversations that bring different thought processes to what the answers might be.
Okay, any more questions or comments? I mean, there's nothing to add to that last piece, is there? So, right, okay, I'm going to move us on and move us on then to the committee terms of reference for the work plan and work plans for the quality and safety and risk and audit committees.
Yeah. Sorry, do you want me to just ask the board to approve the Quality and Safety Committee Work Plan and the Risk and Audit Committee Work Plan, which have been approved by the relevant committees, but missed the board last time, so they're just coming today for approval, and also to approve a small amendment to the terms of reference for all the bi-monthly committees, which have previously stated they were meeting monthly, and we just wanted to change that to say they would meet at least bi-monthly. And that was all for today. Thank you.
So as Liz says, they have been through the respective committees. So any questions or comments, or do any of the respective committee chairs want to add anything? John?
Just to say, for the Risk and Audit Committee, as well as, of course, we reviewed it at the Risk and Audit Committee, it was received from management, but we also took counsel on this from external audit as well, and internal audit. So I think it's gone through the right process. I think it's a good plan. I think, of course, in our second year of operation, it will have a slightly different character, but we endorse this plan as the right plan at the end of our first year of ICB.
Thank you. So can I take a steer? People happy to sign these off? Thank you very much. And then that leads us very nicely, Debbie, to... Yes. Thank you. To the quality report.
Thank you. So, what you've got in front of you is the new quality report. It's in a totally different style than it has been previously. So, it is here for noting. It has been to the Quality and Safety Committee already, and we've had a full discussion and gained assurance from it at that committee. So it's here for noting at the board. But that said, welcome any comments anyone might have around the style of the report or anything that you think is still missing or needs to be added. It is a forever changing and evolving document, and the idea of the new quality report is it will be exactly that. It's not going to be the previous one had set slides where we just had set updates each time, whereas this one is actually driven by what the board needs to know and what the quality committee needs to know and needs to actually address from a focus perspective and a risk perspective. So I'm going to take the report as read. And just take you through sort of how we've decided to do the sections of the report. So we've got a starting section on sort of areas of quality focus to make sure that the board and the quality committee are cited on where we've got our key challenges for that month. And obviously, as Patricia says, this changes quite regularly. So, but this is where we were at this point. So there's a, I'm not going to go through it, but there's a section on maternity services, particular challenges around workforce. That's not unique to us in Dorset, but actually is an area of focus, because maternity is an area of significant focus for obvious reasons, and we'll come on to that later with a further report. But just to assure the board that the local maternity and neonatal services board is in place for Dorset, and actually remains the board responsible for monitoring and ensuring that risks to maternity services are managed, and that board reports formally to the system quality group. So we've got sort of clear governance on maternity services there. The Section 11 audit, so our safeguarding, Pan Dorset safeguarding executive does a Section 11 audit where they go through the various partners, and it was Health's turn to have our Section 11 audit, so we had that. And there was just one recommendation that we're following up around a challenge from the audit process around disclosure and barring service checks every 3 years. So we're just following that up with our providers and looking at there's an action plan in place to do that. And then initial health assessments have been on our risk register for a very long time. They're now off the risk register for the moment, you'll be glad to know, because we are really making progress. There's a task and finish group, so it is still being monitored because we haven't got it to where we want it to be yet, but actually we have seen a significant improvement, so it's heading in the right direction, but still more work to be done. So there's then a section on sort of regulatory visits and outcomes that we've put in there. I'm not going to go through those. I think hopefully the report actually speaks for itself. I think probably UHD and Siobhan will say have been inundated with CQC attendance since September, more or less, permanently in the trust, doing both medicine, surgery and maternity services. So the trust is at the point where they're just looking at factual accuracy. As any sort of immediate actions have been taken place, and draft reports will get back to CQC, and we'll be able to bring them back at a future meeting once they've got to that sort of publication stage. But I think hopefully they're out of the organisation for the moment, because it's very time consuming. As much as it's important, it's extremely time consuming in the middle of a very busy winter that everyone's talked about already. The next section of the report is really talks about sort of quality improvement initiatives. I wanted to make sure that we captured some of the good work we were doing as well, and there's quite a lot of it actually. So the next section sort of outlines some of the improvement initiatives we're making, and then a bit like Patricia's report, some sort of good practice areas is highlighted in section 6. And then there's feedback from the system quality group. So the report is here for noting. I wasn't going to go into any further detail, but happy to take any questions if that's okay.
Thanks so much, Debbie. Rob, are you looking at me because you?
No, I'm just smiling.
You're smiling at me, Rob.
So any questions or comments for Debbie? So I've got Dawn and then Siobhan.
Just a comment, just to say how much I enjoy reading this report. I think it's an improvement on what we had before. So just thank you to you and the team for the hard work that you put into preparing this for us.
Siobhan.
I think the report's really good. I've got a slight question about, can I drill down, which at the moment I can't, but outside the meeting it would be good to know how you can drill down, and I'm sure I can somewhere.
So the appendix has actually got the data, and I think we talked at board previously about every board member having access to DICE to be able to drill down. So I think hopefully that you can get into the detail, but absolutely happy to have the conversation, Siobhan. It's that balance around how much we put in the report to make it flow. One of the things that we did say at Quality and Safety Committee, and I'd already spoken to the team about, was putting a little bit more data in. So under each sort of section, when you've got your maternity services section, we'll pull a chart to actually sort of show a bit more data where it's relevant. But yeah, I think there are ways of drilling down. But yeah, we're happy to have that conversation.
And the second point I'd make is just to properly assure the board, I think when you write the narrative about the areas of quality focus, it might be nice to put a little bit more of a balance into it, because just to assure people, on maternity services, there are some very good things within maternity, and I'm hoping the CQC report will, when it's published, be balanced both in terms of some of the challenges but also some of the good stuff that they saw. And I just think it's quite important publicly that we acknowledge that there will be challenges, but there's also some good things.
Yeah, definitely. And there is a follow-up report later on the agenda on maternity that actually highlights some of the good work that we've actually been doing across maternity. So there is a bit more of a deep dive into it later on, I guess.
Yeah. I guess the only issue is that that report is in part 2, isn't it? Whereas this is in the open section. So I think that I think the point about that balance is well made, actually.
Yeah.
Cecilia.
But I would also say it is delightful to see the good practice. It's great to see those things that have worked. And you mentioned the task and finish group that's being able to address some of the long-standing risks that we've had, and I think that as an approach where you've described success starts to give us those ideas that things can change, will change, and are actively changing. So I think that's good. And yes, I mean, we do have access to, I certainly have been able to drill down through this in DICE, so yeah, that was done. So maybe it was before Siobhan arrived.
She probably hasn't had time to look at our DICE with the data that's actually on a day-to-day basis at the Trust, I would have thought. But yeah, no, that's good to know, thank you.
Yeah, I just wanted to, sorry, Forbes, do you want to come in?
It was just a general question to Debbie, really. It was about, and Siobhan's touched on it, but is your sense that the approach of the CQC is going to be proportionate? Now, that doesn't mean we're trying to not support good quality practice, but their approach on site and their reporting has to be proportionate with the climate in which we're working. It's a concern that a number of colleagues have raised with me. They have concerns about that.
I'm sure
just before you come in, because that was going to be the comment I was just going to make, because obviously within your first 6 months of being here, Siobhan, you've had CQC in, which must be quite stressful actually, because it's not just the level of work, is it? It's also the kind of anxiety that it raises, I think, for people. So I wanted to make that comment that that we recognise it's probably not been easy. I think there are some useful things that can come out of inspection, particularly for a new chief executive. So there's some things you can point to. But I think Forbes' question was where I wanted to go. So
I think generally nationally there's some concern around CQC coming down really tough that isn't proportionate in some areas, maternity being one of them. Certainly sort of regionally and nationally the feedback we're getting is that practically every maternity unit that's getting an inspection is getting really sort of tough findings. Particularly findings relating to workforce, when you actually know you've got workforce challenges and actually you're mitigating for that, but actually, because you've got workforce challenges and you haven't got your ideal workforce, they sort of will rate you down for that, or that's a national issue, and all we can do is mitigate that and make it safe. So I think in answer to your question, I think Siobhan would probably say, she'll probably come in and say, at the moment we're going back with that challenge that actually perhaps it's not proportionate, and I don't think that's unique to us. I think that's a challenge that a lot of systems at the moment are going back to CQC on. It's not about the challenges that we've actually got at the moment, it's about how we're reacting to those challenges, how we're mitigating, and how we're making sure we've still got safe practice. And it doesn't feel like the current sort of style has adapted to that, really. So I think it's a challenging time, but I don't think it's unique to us in Dorset, was all I would say. Really.
I mean, I would add it's quite difficult, isn't it? Because the CQC quite rightly are maintaining standards. Yes. So, I totally accept that. But I think it becomes a bit tricky at the moment in the current context in which we're all operating around proportionality and also consistency. Yes, so it's quite a tricky time. And a lot of CQC colleagues are changing and they're going through very big changes themselves. But there is a lot of learning, and there will be learning for the system. I'm just very aware I don't want the morale of staff to be reduced further, because they are working incredibly hard. Agree. And I'm really proud of that.
I raised it this morning with NHS England because I think there's there's always a challenge around consistency of view and reporting, isn't it, when you've got inspection teams that are down to region and local, and how do you do that normalising process so you do get consistency of judgment, and that's really difficult. But I think sometimes we are forgetting that the inspection regime, yes, is meant to be driving quality, but it's also meant to not expect organisations to be perfect. It's meant to, and the leadership challenge, get assurance that they understand what their issues are and that they have processes for mitigating the risks. And yes, if an organisation staffing is so low that it's incredibly unsafe, that's a reason to rate them really poorly. But if they're facing the challenges that most organisations are facing, and they've got a daily process for mitigating that by moving staff around the organisation, and there is sufficient assurance through that process, then that should be reflected in the rating and the judgment. And we're not seeing that everywhere, which is why the question I asked this morning was, can we have a discussion with the regional head of inspections that says, actually, can we just see some consistency in judgment? Because apart from anything else, if we don't, the ratings are no good for the public, because they're not comparing apples with apples.
I think it's fair to say, just one point on that, I think it's fair to say that I've also had conversations with NHS England, and actually they've been quite supportive with regards to actually raising this with CQC and actually raising that proportionality, but also that consistency argument. So I think we've had quite good support from them as well on this, to be honest.
And I think that's all we can keep doing, isn't it?
I think so.
Okay, that brings the quality report to a close. We've now got a break for 10 minutes. Can I suggest that we resume, so don't be walking back at 22, but let's resume at 22. So you've got about 12 minutes for a break.
Thank you very much, Chair. So the performance report, I think kind of my reflection, because it is November since we last met, and we've had 2 months since then, and the 2 months really has been 2 very different months over November and December. If we look back over November and some of the charts that you'll see, the SPC charts, it's all looking lovely, particularly for no criteria to reside. We've got sustained improvement in the numbers of patients who were no criteria to reside, so they were coming down nicely. We were on track meeting all of our elective targets. We were still doing really well at our diagnostics and cancer performance. And then we hit December. And December has been a much more challenging month. I think partly impacted by weather. We had a warm November, we had a cold December, and that always impacts on the number of patients and the demand for the service. But as we kind of got up to the to Christmas, with industrial action and the greater pressures that there were, we have seen, I think, some of the greatest pressures on our services in Dorset and across the country that we have ever seen. We've had more critical incidents, so it kind of in our 3 level from business continuity up to a major incident, we've had more critical incidents over that time than I think we've ever experienced. The time between Christmas and New Year and up to after the New Year period has been really challenging. The system has gone back to Opal 4, which we came back out of it in November, representing the highest level of pressure that we are experiencing. And we've seen the acute trusts in particular have not just Opal 4 but into kind of critical incident territory a number of times over the Christmas and New Year period in December. So I think that's the backdrop that we are in with the performance. Obviously, the performance is the validated position, so some of it is quite out of date now. So I just wanted to update on some of the latest positions on where we expect it to be. So on elective, we shouldn't have any patients waiting over 104 weeks at the moment. That's the target. We ended November with 40 patients over 104 weeks. In December, that looks like, we haven't got the validated position yet, but we will have 26 patients. At Dorset County, we expect we to be at 0, and at UHD, it looks like there probably will be 11 patients now that will be 104-week waiters at the end of January. So we were expecting that to be 0, but the pressures that we've experienced over December and will experience during January means that there could be those small number of patients that go over. On 78 weeks, the target is to have 0 by the end of March. We are now close enough to March to know who all of those people are who will be 78-week waiters. So roughly across Dorset, there is something like 1,300 that will be 78-week waiters by the end of March. So we are tracking those through. We haven't got dates for all of them yet, but that will be the next stage that we work to. You will remember from the last meeting that we are expecting Dorset County to be at 0 by the end of March. For UHD, there was a kind of just over 100 patients that it looks like we haven't got capacity for at the moment, but still working on and trying to find those. And as we allocate the dates, making sure that we target the long waiters through that. And it's mainly down to a couple of specialties where that capacity is in colorectal and urogynae. In cancer, we are doing kind of relatively well. We are seeing kind of about 70% of patients are getting treated within 62 days of being referred. The national standard is 85%. That's at the upper end of where other areas are across the country. In diagnostics, we are at seeing kind of 85% of patients within 6 weeks against the 99% standard, which is a lot higher than many areas. What I think I'm reassured about is that our activity and the number of people that are being seen every week in diagnostics goes up every week. Obviously it dipped down over Christmas, but we're seeing an improvement in that productivity that we know we need. For UEC, I mean, I've mentioned how difficult that has been during December. For ambulance services, the Category 1 target, the standard is 7 minutes. We have been over double that, so that is really for life-threatening kind of conditions. The Category 2 one, which is the majority of the ambulance responses, during November we were around 30 minutes in Dorset, which has been better than some areas, certainly across the southwest. But over the Christmas period, we saw that rise to over 2.5 hours at one point. Really significant. Fortunately for yesterday, we are back down at 24 minutes, but that is a lot of work that has gone into getting that position. For no criteria to reside, we peaked at around 360 over the summer period, and it's varied between about 300 and 360 since then. We've had some success, and the winter discharge fund that we've got is improving that, as Patricia reported earlier. We've got an additional 90 social care beds that are now available to us that we are kind of finding the patients to go into. And looking forward, we've got the strike days on the 18th and 19th of the nurses' strike, and we've got the ambulance strikes coming for the 11th and 23rd. So I think January is looking to be a difficult month for everything. I think what I want to do probably for next time's report is to make sure that future delivery of performance is more explicit within the report. I think some of it is in the exception reports, but probably not in the overall report. So I'll make sure that is included certainly for next time.
Shocking, you'll take out the plan, Forbes?
I think Forbes has just read some of the reports.
I didn't know.
Had you finished, Dean?
That's Yes, thank you.
Something you said clearly upset.
Before I
Dr.
destroy more
Watson.
furniture. Thank you. I will leave it at that point.
Thank you. Okay, so let's go for questions and comments. Okay.
I was interested particularly in the mental health section for children and young people, Dean, and it's the issues highlighted there have been issues in the system for a while. What I was pleased to see actually through the other reports within it, one of the questions I often ask is, at what point do we think we're going to get this resolved? And I was really pleased to see in the risk register that we're now getting a date and a trajectory for potential resolution of these, which is a real move forward. Thank you very much for that. And I can see that it's now December, so that's really quite interesting because we've got the year to look at how we're getting there. I was talking to David about this earlier. One of the things I would be interested in, because the issue of CAM's performance, there were several things done to try, were supposed to alleviate some of these issues, one of which was the mental health teams in schools, which were supposed to ensure that inappropriate referrals were not being made by schools, were to try and make sure that there was prevention at an earlier stage. I'm not aware of any evaluation having been done on whether they have actually impacted on the issues, because the issues with CAMS has been an issue all my time in Dorset, you know, in schools and things like that. And I'm not sure whether there has been significant impact from the mental health teams in schools. And I know Elaine is involved in the steering group there in that strategy. But if we look at the mental health strategy, we need to see it across the whole spectrum. And I wonder if it would be possible at some point to look at whether that mental health teams in schools, which is taking a lot of resource, a lot of staffing, a lot of people with mental health capacity into schools and outside the system here, whether it is actually delivering in the sense of relieving some of the system. And we never hear about that bit of it. So I just wonder if it would be worth considering an evaluation of that to actually see whether in fact the money has been put in the right place. Now I know my colleague head teachers would probably have my head for saying that, because as far as they're concerned they want them in schools, and Dorset only has 2 areas that had them, Blandford and Weymouth and Portland, and I know they've been really helpful there. But either, if it's working, we need to extend that to release pressure on CAMS, or if it's not working, perhaps we need to be looking at the staffing that's going into that, if it's not having any impact overall.
So I don't know if that's a combination of Dean and Dawn that want to comment on that, but one of the areas in the report I was concerned about was just that sheer swing in the performance around children and mental health services. I mean, it's pretty... Sorry, David and Dawn rather than Dean. But I don't know if it also links to that performance issue that fits up in the report. Dawn, I can see you're pensive, so do you want to come in first?
I don't have the data to hand today, but certainly very happy to do some sort of deep dive and bring it back to share with colleagues at the ICB.
Yeah.
Maybe next time round.
Great.
So there's a few points I could share which might help. So the mental health support teams focus more on early intervention and emotional health and well-being in the schools, and the idea is through that they take the pressure off the core child and adolescent mental health services. And it's a model we've adopted because it's a proven model nationally, and there's been release of funding coming through into previously CCGs, now ICBs, to support the rollout into schools. So far our coverage reaches 150 of the 300 schools in Dorset, so it's not complete. In those that it is operational, it is having a significant impact for the children in the schools. But the impact that we might have seen is being offset by the significant rise in demand and increasing acuity. So these services wouldn't necessarily help if people are in crisis because they need to be referred to the core adolescent mental health services. And we have challenges there, which are being worked on, but there is a challenge in terms of doing that. There are a couple of other things that are going on as well to improve the capacity. We've, in the last 6 months, we've commissioned Stormbreak, which is a local third sector organisation who provides emotional health and well-being support through activity, to trying to support children's self-esteem and resilience, but targeting in primary schools. And that pilot is going to reach 40 of the schools. So far it's out in 20. And they are the ones of the schools that don't currently have the mental health service support teams in place. So we've got 150 schools that do and 150 that don't, and of those 40 are being targeted for this pilot. So we are trying a few things, and it's a good idea to go through the physical route because that sort of combines the holistic person view and not just dealing with emotional problems. The final thing to say, which might help with what Dawn's just described, which is that we have data and there is a plan to bring a report to the system executive group, which I appreciate is not all the board members here, but the system exec groups that previously the system leadership team meets at the end of January, and there's an agenda item to bring a report on MHSTs and CAM services into that meeting. So we'll have something we can perhaps share with colleagues afterwards, or indeed if we want some discussion time on it, we can organise that for the next meeting.
That's really helpful, and that picks up part of what you were asking, doesn't it? So that's really helpful. Yeah, Dean, you wanted to come in as well.
Yeah, just to link it back to the next Finance and Performance Committee, we're going to have a focus on the mental health kind of performance report at that point. So that will feature in kind of next time's board meeting as a feedback from FPC.
Okay. Any other questions or comments then? Is it safe to go to you, Forbes?
Well, I might need some help afterwards, but anyway. I suppose just a general strategic question. You know, the performance is really difficult, but often the focus of performance now is about the ambulance response times, isn't it? And it's very prevalent in the population. And I just wondered, what's the answer to this? Because it's now been around for a couple of years. And it waxes and wanes. I know Patricia's very involved, and apart from getting less people to ring the ambulance, I just wondered what the right direction of travel is. It's an impact on the patients, it's an impact on all other sectors, and it's a problem.
You asked me to have a magic wand.
yeah, but I wondered just what the sense was, really.
Do you mean, are you asking me what's the answer to the ambulance problem?
Yeah.
Andrew's over there if you want to.
I'll give you an example yesterday. So I wasn't in practice yesterday, but you know I spoke later, and we had a 90-year-old gentleman who had fallen, and we think had a fractured neck of femur. I haven't checked. He ultimately sent into hospital. Rang the ambulance trust. The ambulance couldn't come. I think, and I'm just checking this. Local people, perhaps the police, ended up bringing him into the surgery. Now, this is an elderly man with a query fractured neck of femur, and the surgery then managed to get an ambulance to come. Now, I don't want to be critical of the ambulance service, but really there should have been a response to that. And, you know, we are moving from crisis to crisis, really, in terms of being able to appropriately respond. And I just wondered, I think it's very difficult for the ambulance service. I think it's very difficult for the staff. So it's not an observation on them. It's just about how can we make our response better.
So Andrew's here as well. So you've got Paul and Andrew.
We don't often have the ambulance trust in the room.
Okay, so I'll start. I think the answer is it's multi-layered. I think it's getting the capacity and demand right. So definitely getting the out of hospital capacity right, and doing the work we need to do on interventions upstream that manages demand better. I think there is something about making our access to out of hospital services less complicated. Before Christmas, the Wiltshire system have got a multi-professional coordination centre rather than a control centre that we've got, so we're talking about putting that in place. And sat in there, when I looked at, and their system is probably about as complicated as us, how long it took that team to place somebody that didn't need a complex solution, put them in the right place. I'm not surprised paramedics convey to hospital, because quite frankly I'd lose the will to live at that point. 2-3 hours to make something really simple happen. So I think that's another thing we need to do. And I think we need to think about using other parts of our system to do relatively simple things. So again, before Christmas I was having a conversation with Ben Ansell, who's as our Chief Fire Officer. UK Fire Service are commissioned to deal with falls and only get the ambulance service in when they absolutely need conveying to hospital, and for some reason we don't do that. So we're going to have that conversation with Ben next week about why we don't do that and what can we do that's different. So I think it's multi-layered, if I'm honest, Forbes. I think there's some things we can do that would be fiddling around the edges, like how we use the fire service, but I think the longer term piece is how we get the capacity and demand right, and we transform some of the services that we need to around urgent emergency care and frailty, and we might not see the biggest change in some of that for another year or two.
Some of the issue for us as well, though, is it's because of the footprint that SWAS have, isn't it? So I think the largest demands don't actually come from Dorset, do they?
No, they don't, but I think Forbes is talking about for Dorset, not for the whole of the South
No,
West.
I understand that, but what I'm saying is, if the demand is coming from elsewhere, that's going to impact also what we can get, I presume. No?
Yeah.
Sort of.
Oh, okay.
Is this microphone working, or do I need?
You need a round one.
Double mic. We need double mics. From our analysis, I mean, by far the biggest factor is in the handover delays. Every day we have between 20 and 25% of our resource just sitting outside hospitals waiting to get patients in. So until that is managed, there is going to be no solution to it. And that's really critical. And it's not a question of money. We don't need more money. We just need that flow issue to be resolved. And that's everyone in this room has a part to play in that. Echo the factors that have already been raised. So there are lots of issues in there. Improving our triaging process so that we don't send ambulances where they're not needed. We're working really hard on that. We've seen our hear and treat rate go up to around 40% in the last couple of weeks because we've been in such extremis. And we're trying to maintain as high a ratio as we can, but of course that has an impact on patient safety, so it's a hard equation to balance. And then the last point I'd just like to make is really, you touched on it just then, is our infrastructure, which in Dorset as well as the rest of the region is really, really out of date. You only have to look at the standard and location of the ambulance stations that hasn't grown in line with what the model needs to be. The recommendation nationally was to go to a main operating base hub and spoke model. We'd love to be there, but we need the investment in capital in order to achieve that, so that we can put a hub and spoke model in, which will improve efficiency. But our initial assessment to do that across the whole of the South West was 200 million. So quite clearly we're not going to get that level of money, but we need some further capital investment to modify the estate facility we have. So those would be my 3 top points. Thanks.
Thank you. Paul, did you want to add anything?
There's just one thing, and if it's taken in isolation, it probably won't go down well as in a public meeting. But I don't think we have an ambulance problem. Is what I would say, and I think that's really, and it fits with all of this. We've got an ambulance symptom. That is probably the most apparent one in the public domain.
Yeah. Sorry, Natalie, the TV's going off. Sorry, Paul.
So I think we always need to go back to that actually we don't need to fix ambulance problems. We need to fix our urgent care flow, and then the symptoms at where it's bubbling up will settle down, and there are numerous of them, and ambulance is just one of them. I think, having said that, I think the one thing that we can work on is making sure that all the alternatives to paramedic attendance or to conveying into hospital are as easy to implement as the conveyance or the calling a paramedic. Because often it's time pressures and it's path of least resistance that drives a lot of clinical decision making. And it goes back to Patricia's point about how long it takes to then try and sort out something that keeps someone safe at home compared to getting them in and getting them into hospital. And I think that would be a real help along the whole of our pathway. But yeah, it's a symptom rather than the problem, I think.
And those bits of the pathway, we have plans in place to try and fix them, do we? Or
so there's lots of points in the pathway. There's so many pieces of work going on. I mean, Dean would easily be able. There's in numerous meetings of bits along the pathway that we're trying to create as much capacity in those elements in order to promote flow. There's still work to be done on the ease of use of those of some of those alternatives, and I think that's an ongoing piece of work that we shouldn't let up on.
I agree so, false question about when then. What's your best estimate as to?
I think we'll start to see some steady improvement from next year onwards, but it will take us a good 2 years to get to where we need to get to. But the other thing I would say, which you can close your ears now, Andrew, because I know this is not popular with the Association of Ambulance Chief Execs, is if we're going to have control and flow rooms that work properly, and we're going to have a chance of changing people's behaviour so they don't automatically ring an ambulance when they don't need one, I think we need access to the stack. Because once we start to pull from the stack and we start to divert people to different places, they'll stop ringing an ambulance because they'll see that ringing an ambulance is not the right answer. Whereas we can keep saying over and over again on the comms, please don't ring an ambulance if you're not desperately ill. And the reality is they will, because they know that they used to know before we had all these delays, that if they went to A&E, it's the only place where the lights are open 24 hours and they'll get an answer straight away. And one of the ways that you change behaviour is by stop giving people access to different things. So I really, really believe that if we've got a set of clinicians in coordination centres who are more than capable of triaging people, we should allow them to pull from the stack.
What do you mean by stack?
It's the stack that the ambulance service holds. So they get a call, they'll prioritise it, and then if you're not category 1, you're in a stack. And we should be pulling from it to get people to see that there are different alternatives.
Siobhan?
Patricia at the beginning talked about demand capacity and actually the whole flow issue, which obviously this is what it is about. It's not one sector, it's not the ambulances, it's the whole pathway. And I was talking with some of the clinicians over the last couple of days in A&E in Bournemouth, and we were really sort of saying, what else can we do? And the worry for me about the timeline is that actually we probably as an ICB, it would be really good. I think what we're trying to do is create a much sort of faster pace of change where we test things. If they don't work, we do something else. If we're doing something and it's not having the impact we need, we amend it. And I suppose at the moment, I'm really worried about the strikes, especially the nurses' strikes, which are 2 weeks away. So actually, I would be challenging us outside the meeting to really think, what have we learned from the stuff we've got in place at the moment in terms of impact? What can we do over the next couple of weeks as a system that we think might change, tweak, do something that actually can help the flow, either in terms of averting from the front of hospitals or supporting the flow out through the discharge pathway. And I think we can all contribute to that. But I suppose my worry about our sort of discussion about timescales is it feels not as quality improvement as I'm trying to describe. And I think there's quite a lot of resource at the moment because money actually doesn't really fix this. We've got to be brave together to do things quite differently and try some different things to get people in the right part of the system.
So you're talking about pace.
Yeah.
It's not just personal, is it, Siobhan? It's also about people recognising that we don't need to wait. David says this all the time. We don't need to wait until a plan's perfect before we go forward because the world isn't perfect. We need to make sure we've got enough steps in place to try something, and then we learn as we go along and we adapt. But we've got into this habit of being a bit risk averse and wanting the plan to have all the T's crossed and all the I's dotted before we move forward, and it's not realistic.
So what do we need to do then to enable David to have the world that he's trying to create where people will just put their toe in the water and go with it? Is there anything you need from the board, from the players, the partners sitting here to do to help that?
I think there's something about creating an environment where people are okay to have a go and fail because they know that's a learning exercise, not a point at which we all retrench back and don't go forward. Because that's how most of our staff will learn, is by getting things right as well as getting things wrong.
So I've seen lots of hands and I've missed who was, but I think Dean was first, and then what I was going to do was go down this side. Oh, Debbie was first. What before? Neil? Before Dina.
She's been doing this for ages.
Oh, no, I have, it's fine.
She's been doing
I
this.
Debbie,
I was doing a Rob then,
Debbie,
wasn't
and then Dean, and then who have I missed? There's Dawn. Okay, so Debbie, Dean, then
I
Dawn.
don't know if I need to speak, I think. I was just going to come back on what Siobhan was saying really around pace and trying to do something different, and also around what Patricia was saying around maybe not getting it right first time. Dean and I have been working really closely on this, and I've got a team from my team going into work with the Trust from Monday, literally. So we're going Bournemouth and Bournemouth sites next week, and then we're going to go on to DCH and GHC as well. So just literally work with matrons, do the walk around the wards, see what we can learn, actually review every patient. I'm not sitting here saying that I don't know how much of a impact that's going to have with regards to how many exact patients we're going to get out the door next week or the week after. We don't know that, but certainly what we do know is that we will use it as an exercise to actually identify any sort of areas of that we can move quickly, areas of process that are actually blocking. So I think it's going to be done as a bit of a learning exercise, and I think there's quite a lot of that going on, and I don't want people to think that we're not trying to do something at pace, because actually we are, and that's just one thing we're trialling, but actually there are others as well. So
okay, thank you. Dean.
Link it, because later on the agenda, I know it's just for noting, but there is the winter plan that we've put together. Now, I think I've been around winter plans for many years. This is probably the first time that kind of a winter plan has been so out of date and historic, kind of the moment that it's written. And we didn't write it until really late in the year, just because there has been so much happening in terms of new funding coming out, new things to respond to. But I think the environment that we're working in, having to respond to kind of new pressures that come along that we weren't expecting when we were first putting the plan together. So I think the other thing, just on things that we can do, I think we've got a lot of capacity across the system, both in our services and in the way that we manage them and how we can make changes. But I think we get tied up a lot in carrying on the things that we've already done, and we need to, at times, like today, change what people are doing to be able to take some of those risks to do some of the new things, because what we planned to do a month ago in a stable November where we were improving the system is different to what we need to do in December and now in January, when we are responding to a system that is really under pressure. And kind of, it's an overused word, but I don't have anything further to describe, I think, the amount of pressure that we see every day, every week, and it feels more, we get almost used to what was last week's pressure, and then we push a bit more the following week. And that's what it's been like over Christmas and New Year. So it's how we respond to that, what we can change, and what we respond to kind of those changes that we need to put in. For example, now with the new RCN strikes and with the ambulance strikes coming up, we have got to do something different before we get to those, like putting that, pulling from the stack, or kind of, we haven't got kind of 6 months or so to plan it. We've got to put something in kind of this month, this week, to actually respond to things like that. And I think that's the thing that we've got to change, the culture of way we work and the support that we can give all of our teams to be able to do that. Because it'll be scary places for them, because they won't have been here before. They're experiencing things that they have not experienced before, and that causes stress and is difficult to achieve.
I mean, I don't think Siobhan's here at the moment, but I think that's exactly what Siobhan was saying, wasn't it? We need to do something now to manage the next few weeks. So it sounds like you've got that to mind. I guess part of my worry is that I think one of the roles that the system, the ICB as a system, needs to play is that we are also looking to the future, so that we're not just constantly just responding to the next issue. And so somehow, Patricia, you and the team need to somehow keep that capacity also for planning, so that by next winter we're managing ahead of having to respond, if that makes sense. And it's a challenge, isn't it?
We've got to manage today's pressure, and we've got to plan for next winter. So we've done that, and it's described in the winter plan kind of how we've tried to do that.
Yeah,
we split our
and
work
that's really
into
good, actually.
3 sections.
It is.
So the first one is responding to today. Second one is what can we make better for this winter in the next few weeks. And the third one is how do we plan for next year. And that's the way the Urgent and Emergency Care Board work has been set now. Now that third one, we're not going to start until kind of February, March time, because we need to do the first 2 and we need to provide the capacity for our teams to deliver on those first 2.
Okay, thank you. Dawn? Okay.
It's fine.
Okay, anybody else? Anybody that I've missed? Dan?
Can I pick up on Patricia's point? I think the whole kind of fail fast, I guess it's fail safely. In terms of tone from the top, I didn't get a read from anyone who's anti that. And you asked the question about what can we do. Probably not that much we could do other than help to contribute to the culture that that's okay. And so I just, not put that on the record, but I think it's a really important point about how we can help. And a lot of it is about tone from the top, which the board has got a key role in. Because if we set ourselves up to assume that everything we do will deliver the benefits that we plan to, we'll never do anything because it never will. I just want to remake that point.
And I think it's an important point about the culture, isn't it? That what you've got is the backing of the board for the culture that you're trying to set. And if there's anything else you need us to practically do to help with that, then let us know. And I don't just, I mean, there's lots of partners around the table that could probably help with that also.
If I can jump back in, because Rob and I were speaking about the risk appetite, and I know that following the risk register work, that we're going to look at the appetite, and there's something about the transformation risk where we can build in that fail safely bit as I think that's work ongoing now or over the next couple of months, because that's the other place it can live.
Yeah, Rob has put that in the chat actually.
And that's a really important point, and because the other thing we're really grappling with is getting people to put numbers and dates that say I'm going to improve by this point and this is what it's going to look like. Now, that might be a symptom of all sorts of things, but we've got to get to a point where we get people putting their improvement trajectory down and when it's going to be delivered. And then if we get to a point where we know it's not going in the right direction, we can talk about extra support. Exactly. But what we can't do is sit here with a how long's a piece of string conversation.
And that's a cultural change as well, isn't it? So, yeah, thank you. Karen, sorry, Karen, you put something in the chat about razor chairs, and I've no idea what it is. I know Patricia's asked you the question. Do you want to expand or do you want to take it offline?
No,
is it just chairs that raise people up? Is it?
It's a service we ran when we were the preceding authorities, ran in Poole for some time, and we are expanding it across a conurbation. But basically, it's our service. Gosh, mine's gone blank. I can't remember the name of it, but it's a service where like a telecare service, where people who are signed up to it, if they have a fall, we send somebody out with this chair. It's amazing. I've actually used it myself as a trial, I have to say. I didn't fall over, but it can lift people up and it can save having to have an ambulance come out to lift somebody, and then the operative stays with the person until they're absolutely sure that they're safe and well and they don't need any more intervention. And it's a really fantastic service, and it needs investment, it needs promotion, and we have over the years tried to get support from partners because it is saving the system quite a lot of money when it's used. Happy to send you more details about it if you would like me to.
Is it David to link in with?
David, do you want that? It's probably not dissimilar to what the ambulance service use, that inflatable thing.
But Karen's talking about it. Yeah, but Karen's talking about a service aside of ambulance, which might be one of the things that we need over the next couple of weeks, mightn't it? So, David, can we leave you to link up and Thank you. And then Cecilia, you wanted to come in.
I just wanted to ask, obviously the test and learn I'm absolutely in favour of. I think that's absolutely something we should do. And it does come through in those patient voices that we heard earlier on, that they want something to change. But how are we going to communicate to our service users that they might actually see those differences? Because again, if you come at it from that side as well, there might be, again, some support for changing things. I don't know whose role that is to do that part of the work, the communications to the communities.
It's Dawn.
It is. That's part of the. Okay, so that should be part of our thinking. Because if when you go into a service you expect the same and you get something different, some people might see that as a positive.
Substandard and others, yeah.
Just making sure that we're ahead of that, or at least in line with it, because then you get that positive reinforcement of the change.
And it's also partly about managing expectations, isn't it?
Yeah.
So, Ben?
I suppose I just wanted to comment that I think it's really difficult to portray the pressure. I think it's really difficult to portray the pressure and the desperation that staff are feeling within the system in reports. I think it is actually really helpful, that verbal update over the past 6 weeks, because I think it portrays better what some of us are really feeling. And I think going around to the change agenda, I think crisis necessitates change, actually, and I think the moment is right for that and fast-paced change, because I think the clinicians that are working in the system are already increasing their risk appetite quite dramatically and taking risks that they haven't taken for a number of years just to get them through the past 3 weeks. So I would support that, and I think I would support the pace of change, and I think the appetite is definitely there amongst the clinicians in the system to make some rapid change.
Thank you. Okay, I'm going to move us on. I think we're all in the same place on that, and move us on to the finance report. So over to you, Rob.
I'll try and get through this fairly quickly to give Dawn and Debbie a fighting chance to get through. So the report, I'll take it as read. It's a month 8, which is November. Clearly, we're just in the middle of doing month 9 reporting at the end of December. Month 9 is a really important month for the NHS in terms of its finances. It's the sort of like the month that you kind of decide whether or not you're going to move your positions or not. And we've got the first agenda item, so I can talk more in part 2, where we're going to talk about the risks in the forecast position that we've got at the moment in a lot more detail. Already, Paul? Okay, thanks. So just real quick summary of the points in the paper. So at month 8, the system is looking at a 23 million year-to-date deficit. 13 of that sits in the ICB and 10 with the providers. If you did a simple extrapolation, that would get you to around the 35 million that we've seen previously, the year end, which is a long way from the break-even plan that we all agreed in our first meeting. Buried in the appendix to the finance report, you'll see the mitigated position where the providers would, at the moment, are reporting that they could pull that back on their side to the break-even position, but the ICB wouldn't be able to do that. That would be sitting with a sort of a 19-20 million pound deficit. So that's based on the numbers that are in the report there. Reasons why the costs are more than the income, where we are so far year to date, in the providers and I guess in local authorities as well. Demand, inflation, that's just driving lots of this cost. More for the NHS side of things, we've got the detail around the agency and additional sessions as well. The agency work is making a difference. It is beginning to show some signs of improvement, and that's baked into some of the mitigations that we're looking for in some of the providers through to the year end. In terms of the ICB, the main drivers, you've heard this before in the development session as well, it's the personal health commissioning, so the CHC costs, the independent sector prescribing, and also not having the system efficiencies that's sitting as a system risk in the ICB. So that's where we are. There is one good news point in there. It's in the cover sheet around the payment performance by the ICB, and that is important. It's all your providers. We pay 99% of all of our invoices on time, so all the periods we're meant to do. So that's really good news, because actually there's an awful lot that goes behind that. So it shouldn't just be taken as something that just happens. It's quite a lot of effort on the part of the teams to do that. So there's a couple of pages at the back as well about the local authorities position, but that's in month 6, so again that's a little bit out of date because it's based on the information that's in the public domain. I'll stop there because we covered a lot of this at the board development session last month.
And as you said, we've got the paper later on around the outturn. So any questions or comments for Rob? Siobhan?
Just a bit of an obvious comment, really. Just at the moment, all the extra capacity that we're putting in place, even like ITU provision, we opened to additional ITU beds in the last 2 weeks. You know, the risks are quite paramount.
Yeah, it's a bit like Dean said, this is my vague report sitting in front of us and the world's moved on in month 9, hasn't it? Hence the conversation in an hour's time.
Okay, so I'm going to suggest we hold any other questions until later, and then I'm going to move us on to Dawn, who's doing the international recruitment update.
Thank you, Jenny. So, this paper, following a video shown at the board some months ago, this paper is an update to the local action that's being taken to improve the experience of staff recruited from overseas. And my thanks to Sarah Tilbury, who wrote the report. So, a few key points to pull out. International recruitment has grown significantly in Dorset from very small numbers in 2017-18, and while the majority is in nursing, we're seeing a growth in medics and also some smaller scale social work recruitment. At the risk of generalising, I think it's fair to summarise that the experience of early recruits was poor. Due to a lack of understanding by organisations around people's needs. And since 2018, there's been a lot of learning and very much a commitment to listen to staff experience and to take action to address. And in the last few years, Dorset has been part of the National Stay and Thrive pilot and has had a big part to play in how we improve experience of overseas staff recruited from overseas nationally. And I suppose this is reflected in that there's no significant issues with retention rates. But that doesn't necessarily indicate a positive experience. So just because our retention rates are okay, we can't accept that this means that everybody's experience is okay. So action that's improved experience has centred on pastoral supports, what's within our control around accommodation, how we help people to integrate into local communities, education and career progression. And this needs to continue, and I think there's lots of opportunities to join up more of as a system to progress this. But the issues that remain are the ones that are more difficult to address in the short to medium term. So the cost of a family home in Dorset, the transport in rural areas. And now, of course, how much it costs to live in the UK in general. So whilst the ICS longer term planning can begin to address some of these more difficult factors around key worker housing, key worker transport, the people plan for our ICS needs to be about balancing overseas supply with local supply, and building on the good work that we've already started around accelerating opportunities for our local population so that we can provide health and care, career pathways and progression that improve the lives of people within Dorset, at the same time as making sure that our overseas recruits are still important to us, and we need to make sure that Dorset is as welcoming an environment as possible, so that people can thrive. And part of that is being honest and upfront about the challenges of living here. And over the medium term, we'll be reducing through our approach to local recruitment and career progression, we'll be reducing our reliance on overseas professionals and offering more opportunities locally. So those are the key points that I wanted to pull out of the paper, but of course happy to hear comments and take questions.
Thank you. Dan?
Thank you. Thanks to Sarah for the report. It's really good to have it back following the... I remember the video, and I think it was a nurse who'd come out to get a bus that ran every hour, and it was dark at 4 p.m. and it was a different country, and so it's good that kind of it's come back round. I think two questions if I can. The last picks up on your... I think where you're going with your final point. The report left me thinking about next year, and I noticed the trajectory went from 350 down to about 200 this year. is that a good thing? Is it a bad thing? And you just touched on actually more local opportunity. And I just wondered what was in our plans going forward for international recruitment, given that workforce is such a big part of our risk outlook. And so it's a where we are report, but what does it mean for the future in terms of the level of international recruitment that we anticipate? And then the other bit was how you talked about retention anecdotally looks okay. How easy or hard is it to get the mechanisms in place so that we don't turn it into a retention problem? And is that a big ask? Is it a small ask? Because what we'd like to get to, I assume, is a decent KPI or whatever you want to call it to make sure that there's not a retention issue. Because whilst the anecdotal evidence is reassuring, and kind of what's the data saying, but it was really good to get back into this topic. Thank you.
Are you happy for me to answer
yeah,
directly? And I'll take your second point first, Dan. So on the KPI for retention, we have KPIs around general retention. What we don't have yet, and we can develop, is the deeper on specifically on staff who've been recruited from overseas. That said, what each of our provider organisations are sharing with us is their regular mechanisms for listening and feedback, and those channels for staff recruited from overseas to feed up concerns. And that is much more robust than it was back in 2017-18 when Dorset first started to do this.
Don, just the trajectory to get the data, is it because it's a huge manual exercise to pull it out from the general retention? Is it a data or a system issue? Or so how quickly is it solved?
So it's a huge manual exercise to pull it out because it isn't automated in that way at a national or local level.
Okay. So there's no quick fixes? Or
no. But your first point, Dan, about what now for international recruitment, we've still got a supply problem and we've still got a need. So we need to continue with our recruitment from overseas as we I can see a bit of a jaws of death on a spreadsheet to show that as we grow our local population through a career pathway, then people start with us in non-clinical support roles, and then we take them through a journey to through clinical education. That takes time, and we'll still need our staff recruited from overseas as we grow that part of it. So we can't stop continuing to improve the experience, but I think what we can do is keep doing what we're doing, join it up more of a system, and make sure we're being really open, honest and upfront for people who are joining us from overseas about what to expect. And then they're making people are making an informed choice to come to Dorset.
Thank you.
Okay, so I've got Matt, then Debbie, then Patricia.
Can I grab the second mic? Brilliant. Thank you.
Someday you're going to sing that.
You really don't want me to do that. I think. So we've also experienced overseas recruitment as local authority, had good retention rates from that, smaller cohort number than you're talking about in the hospital system. I think it'd be good to take some shared learning from some of that. We've had good retention, but it's hard work. It's hard. I say it's hard work. It just means consistent effort to make sure you're constantly working with a person through the onboarding process, and then as they're coming into the workforce, and understanding those wider challenges of living and working in Dorset that you kind of alluded to, because a lot of the issues and challenges that our overseas colleagues find is not to do within the workplace. Although I recognise the video last time did present some issues within the workplace. Some of them are not within the workplace, they're within our communities, they are the housing issues. And I'll finish on that piece. Housing Roundtable, which we committed to last time, we have now got a date. That's the biggest challenge, and that's one of our challenges as a system when we want to move at pace, is to get a date and to keep all the key players around the table. But I've committed to that. It is going ahead, I think, in early February, and I'm just going to keep with the date now. So if you can't make that date now, sorry, send somebody else, and we'll just keep going on it, because it'd be really good to get that conversation conversation going about the challenges for housing, particularly not just for our overseas recruits, but also all of our recruits within the system, because that's another challenge we're facing, is the affordability of living and working in Dorset.
Thanks, Matt, and please stick with that date because that was a critical part of the last discussion, was it? So thank you for getting that sorted. Debbie?
Yeah, I need a mic, sorry.
Oh, yeah.
Don't think anyone can hear me otherwise. Thank you, Dawn, for the report, and to Sarah. I think it was really helpful, and I just wanted to reiterate what Dan said. I think it's really helpful to have the report back following the video last time. It's really good to sort of have that follow-up from it. I just think sort of this builds a little bit on what Matt was saying, really. I just wonder whether there's an opportunity, and it might be that we've already started this, but if we haven't, is there an opportunity to do more of the pastoral support and the mechanisms on a system-wide basis for Dorset, particularly in view of the fact that there's learning that's already been embedded from our health trusts that have actually sort of further down the journey than it has been for our social care colleagues, for instance. So I just wondered whether there's, something that we can do on a Dorset footprint a bit more around working together on this.
Do you want to come in after Patricia? So, Patricia.
Okay. So there's a lot of really good stuff in here. I think there's things that are missing, but probably because they're not that easy to put down on paper. I think there's a massive connection between what we do around equality and diversity and inclusion and what we do around overseas recruitment. So we can provide all the pastoral care that we want, but until we get organisational cultures to the place they need to be, overseas recruits are never ever going to feel comfortable. So we've got to accept that, and we've got a journey to go on in terms of that work. When we start to think about the softer things, not the hard things like accommodation, like career progression, we need to really challenge ourselves in terms of how we view talent, how we view capability, how we view ability, and how we view career progression, because lots of our leaders will come at this from an English Anglo-Saxon perspective without understanding the cultures of the people that we are recruiting. Until we understand some of that in more depth, we're never going to get the maximum benefit out of having people in our service from overseas who will bring a completely different skill set. So I think we just need to recognise some of that, and we need to start to think about how we address it, because until we do, they're never going to reach their full potential. If we think about some of the people that we have now from Southeast Asia, they can teach us a lot about how to behave in a collaborative environment, and we're not using their cultural background to do that. The UK is based on individualism, it's based on hierarchy. They come from societies that are based on collectivism, around shared purpose, and we're not using some of their cultural background and skills to be able to help us develop in a way that we need to, because those are the skills that are going to be needed for ICSs going forward. I think there's also something about the fact that lots of the nurses we bring over from other countries have worked in very specialist areas, and yet we automatically assume that they need to go through a BSCI exam in order to become a BAM 5, and then we need to sign them off to do blood pressures, IVs, all this stuff, when they've probably been sitting down in theatres managing heart transplants in India. So we've got to get over this idea that UK training is superior to everywhere else in the world, when the reality is it's based on UK training if they were as part of the empire, and start to think about how for some of those individuals, how we expedite their development into more senior roles that are very similar to what they've come from. So until we deal with a lot of that, we're not going to see, one, people staying and retention being good, and two, us getting the benefit out of the skills that they have in order to reach their full potential, so the NHS benefits from them. Because we've got to get out of this idea that Britain is best and everything else is second best, because it's just simply not true.
So I'm wholeheartedly with you, Patricia, and I won't repeat any of that. The only thing I would query is that I think the issue about them starting at band 5 is a national requirement,
Yeah,
isn't
I know,
it? So,
I know.
so the thing then is about how do we influence nationally to do what we're able to do, or can we even set ourselves up as a pilot or something?
Yeah.
So, yeah.
I've been having that conversation for months.
Yes. I'll leave it with you because I was having that conversation when I was in the centre. I'm not there anymore. Manish.
Thanks. And first of all, echo it's great to see this report after I wasn't at the last board but managed to watch the recording of it, and it was quite a powerful video, wasn't it? So to get this it is really good. Thank you very much, and thank you to Sarah. A couple of things. I think 3. Actually,
that's more than a couple.
That is more than a couple. Sorry, that's my Navy counting. So the first is going back to that. It would be really good, I think, to get a clearer indication of that retention thing. Is it really not an issue, or is it an issue? And how we get to the bottom of that, I don't know. Needless to say, we're facing a very similar problem in the armed forces as well, because we get a lot. We take a lot of foreign and Commonwealth recruits, and trying to get underneath that can be really difficult. So I get that, but given that we know that there's a career progression issue, I wonder about that retention piece. Secondly, another thing that we've been trying to address is how exactly are we defining international recruits? So there's the obvious thing of, well, they're directly recruited from overseas, but some of them will be directly recruited like that. Some of them will then naturalise, and at what point does that specific support need end? Well, it kind of doesn't. Some of them, some people will come from overseas earlier. So when you're talking about developing and building and growing that locally grown workforce, well, the two are not mutually exclusive, because people may well come from overseas, then enter into that pipeline at that point. So there's a bit there for me about how exactly we're defining international recruits and what that actually means. Thirdly, it's really interesting what was said just before about housing and stuff like that, and I'm struck by that old thing about a rising tide raises all boats, and addressing many of the issues faced that you've identified in the report and in your brief just now, addressing some of those issues, whether it's housing or cost of living or whatever it might be, or skills development and so on, for international recruits. Well, actually, that will help all of our workforce. So those were my 3. My final one, Patricia, you mentioned about that mutual learning, which I think is really, really important. But that's important when we get international recruits here, because that gives us that opportunity. Is there scope to do some of that mutual learning at source over there as well? Because actually health cultures and healthcare cultures are different, and how do we exploit? Seems like a nasty word, but I'll use it. How do we exploit that opportunity at source, at distance as well?
So Dom's quite a lot there, and I'm conscious I want to get us onto your next paper, and obviously Debbie's got a paper as well. So
I'll briefly wrap up everybody's points and then link to my next paper, because it does link. So on Matt and Debbie's point about shared learning and Dorset-wide approaches to pastoral support, absolutely, I think there's definitely more that we can that we need to do there, that we can do. Patricia's points about how we influence nationally career progression. We must continue to lobby, but also we must help our own teams risk assess and be prepared to flex within guidelines. And I think, and then Manish, your last point about how we define an overseas recruit, and at what point does that person not become an overseas recruit? Well, for the purpose of this paper, we're defining it as an individual employed directly from overseas into an individual organisation. But as we go, as people progress in their career and change organisations, then of course that their experience still really matters, and that leads into the next paper, which is on the experience of staff from minority communities.
Sorry, I forgot. I was going to bring Dan back in. I've just remembered, so just really quickly, Dan.
I'll be brief. Patricia's first comment about cultures and not being blinkered by British culture. I think you made the same point when we saw the video. In a good way, kind of made the same point. It just makes me think about the forward plan. And is there a ICS or a trust that's really good at it that we can learn from? Or should we set ourselves as an ambition for ourselves to really get under the skin of that and do it as a pilot, as part of the forward plan? Because your comments have struck me both times, but we've got to do something about it, and it might fail. It might.
The people plan, because Dawn's really focused on this. It'll be in the people plan, but no, there isn't anybody that does it really, really well.
But therefore, there's space for us to set ourselves up as doing it well.
Let's do it. And I think it does link to the next paper. But go on, John.
It's a very quick build, which is I noticed that particularly a lot of nurse retention comes through agencies, and I bet those agencies work nationally. And in some way, if we can get these nuggets into our channels and into those conversations, I think 500 nurses, I think you've had over 2 years, how can we get this into our narrative? So at least when those agencies go out, Dorset is one of the best places to be for that person who's considering coming to work in a different place.
Because Dawn's focused on nurses. We've got exactly the same issue with medics in that.
And care.
I think it's worse with the medics, if I'm honest, because we bring international medical graduates. At least our nurses get 12 weeks, is it 12 weeks or something, on preceptorship. Our IMGs get 1 week longer shadowing than our UK trained doctors. How the hell can you familiarise yourself with the NHS and the culture around you in the community in 3 blinking weeks? And then we say, off you go, and then we wonder why they don't perform?
There are companies who do this very well.
There are, and we can be learning from them, which is the point John's saying. So let's go into the res and the des, because this is the other side of the experience, really, isn't it?
It is. Thank you, Jenny. And I'll invite Fran to come and join us at the table. So
Hi,
Fran is the...
in person, haven't I? Is this the first time I'm meeting in person?
I think you might have, but
Have
not
we?
very,
I've seen you lots on the screen, so welcome anyway.
Thank you.
So Fran, thank you for authoring the paper. The paper was also heavily influenced by Emma Hallett, Chief People Officer at Dorset County, who is the system ED&I exec chair. And I want to frame the paper and summarise some of the main points, and then as we go over for comments and questions, I'll bring Fran in for more detail. So the framing of this. One of the 4 priorities of our ICB is to tackle health inequalities. And to do this, we need a diverse workforce representative of all our communities. And we need to make sure that the experience of all of our staff supports well-being rather than detracts from it, because our staff are our communities as well. And we need to make sure that all of our staff understand principles of pro-equity so that we can use that as a lens through which to look at services and then to transform services to be able to deliver on health inequalities. So with that in mind, with thinking about how we go forward with our ICB priorities, this report was to provide a baseline position on equality, diversity and inclusion across Dorset that will inform the priorities in our people plan. The title of the paper, Res and Des to Inform the People Plan, is not broad enough. It's more than that, and primary care and social care don't currently use that metrics, and we're looking at the experience of all of our staff over across Dorset. So the paper was discussed in full at PCC, and it's here for noting because it's so important as an underpinning to our priorities. And you'll, as you read the paper, you'll know it's sobering that despite collecting data for many years now, very little has progressed. And this report highlights the need for that step change in how we attract, retain and develop people from minority ethnic communities and communities with broader protected characteristics. So the need to significantly improve the experience of staff from minority ethnic and disabled communities being bullied and harassed by patients, by public and other staff. And it's also quite stark in the report that we need to understand more and address the high levels of staff with disabilities that are involved in capability proceedings. You can see in the report the positive impact the work Dorset County have undertaken since 2020-21. And this green shoot of an approach shows us that Dorset can grasp this and take it forward, and we can make it a priority to become a leading system in this work. There's the opportunity to scale and spread the stuff that's happening there. What this gives us is an insight into what we need as priorities and action in our people plan. And this people plan needs to provoke a step change around EDI that will underpin our delivery of health inequalities. So that's the lens that I'm requesting that we look at this work, and Fran will be able to talk more detailed about the data if that's what you like.
Can I just add a comment to Dawn's?
Yes.
Because I think that I'll be really careful what I say.
Do you want to come back to it later? No.
What I would ask is that as part of the work that we're doing on the people plan for the system, and we will engage all of our partners in that we agree on one plan, not every organisation doing their own thing around ED&I. And the reason why I say that is because what we've learned at Dawn and I in a very long journey at Dorset County, having tested lots of different interventions, is that we now know what works and we know what doesn't work. And the NHS spends a lot of time on interventions in this space that have no evidence base, that don't work. So we'd really like us to agree as a community of leaders that we'll take a set of interventions that we now know do work, and those are the ones that we'll all commit to, because otherwise what we'll see is still what we've got now is a variability of experience of staff right across health and care, and that's not helpful when we're trying to recruit to one Dorset.
So Patricia, that sounds to me like a recommendation that you'd want the board to agree to, but do you want to come back to that when we've got the people plan, or are you wanting us to make a commitment today to that?
I want us to make a commitment today that we're going to sign up when we've developed it together to one plan and we're all doing the same thing.
That's fine. So I am going to, rather than go into detail, I'm going to hand over for questions and comments, but if there are people that want to think about go into detail, then you're going to have to let me know, because we are running way behind time. So I'm going to start with Jonathan.
So a really good report. I really enjoyed reading it. Really dismayed that it's still an issue. I had really visceral personal experience of this when I was in NHS Choices, trying to get my deputy into a position. I had some breathtaking conversations, which just left me staggered. Kind of to echo Patricia's point, there is an evidence base about interventions that can be taken. I think I talked a lot at the time to a guy called Roger Klein, who's a professor in East of England. He wrote a report called No More Ticks Boxes. That is brilliant. It has really good evidence-based approaches. If we're going to do it, let's do that. It's not rocket science, but it really needs to be done, and it would be really good if you could just knock it on the head and never come back to it, because it really needs to be done. It's a sore in the NHS. Okay.
The no more tick boxes is just on recruitment, though. This is broad.
Yeah, I mean,
So
so I was my particular focus on
Yeah.
recruitment onto
Yeah.
higher positions, but I mean, obviously, all bullying, that's also really quite horrible. It needs to be sorted out.
Agreed. Did I see another hand? No. So, just quickly from me then. The first thing to say is I like that the report talks about equity, because obviously the legislation talks about equality, and equality and equity are two different things. So I really like the fact that we're moving to thinking about equity. So thank you, Fran and Dawn, for kind of taking us on that journey. Second thing I wanted to say, it's not as positive, I'm afraid, but as the person that had responsibility for this as the national director for both the Res and the Des, I was actually quite upset and embarrassed to be reading some of this report and to see where we are as Dorset. I do feel that I want us to be exemplary in the way that Dan spoke about at the previous item. So I think we need to be doing absolutely everything we can to be exemplary, so that to ensure that all of our staff have a really good experience. And I certainly support what Patricia's saying around let's have a consistent approach, because there are interventions that we can do. And Dan, you asked a question about international recruitment. Are there any organisations that do it well? Because I was a national director for EDI, I can tell you that there is no single organisation in this country that does the Res well or the Des well, not one. So that's a failing for me on behalf of the NHS. So if we could actually take this on board and make sure that we are giving all of our staff a really good experience, then I would encourage us to do that. So kind of ending on that soapbox, that's the bit I wanted to say. I just think we've got to do better, because particularly if I focus on ethnicity, particularly geographical areas that do not have a mass of people with black and brown skins, the challenge is much more difficult, and the experience that they have will be more challenging. So we have to think doubly hard about what we're doing and how can we make sure that they are getting the best experience. And I know when Patricia, if you don't mind me saying, was chief exec in DCH, that you had some really challenging experiences that you spoke to me about when I came in. So this doesn't stop when you get very senior in organisations. Racism, sexism, etc. carries on. So we've just got to be really active. And for me, that's the whole thing around anti. It is an active verb. It's not just to sit down and wait to see what happens. It's an active verb. So I'll get off my soapbox and I'll go to Kay.
I was just going to say I really support your idea that it has to be across all areas. I was involved with the EDI group at the CCG, and it really had a lot of thinking to do to move it forward. It was very much in its infancy, and we really need to build on good practice and really embed all the issues properly across the system. And it comes from that EDI culture first, and not just from the data, but the data is always a wake-up call.
And I think in the report it says there isn't data available for primary care, and that's true, there isn't. But what we do know about primary care is that if you are non-white and you run a GP practice, you are much more likely to be rated as inadequate. And I don't believe that all ethnic minority GPs are rubbish. So what I would say as well is that some of this requires us not to do process, but it requires us to think really deeply about the way that our view of the world has been developed through a whole range of experiences, right from childhood to adulthood. We are doing a lot of work as an exec team at the moment with a coach in this space, and actually I'm really pleased that everybody has been open and willing to have their experiences and their views about the world challenged. But that requires all of us to do that. And if I give an example in our system right now, and I'm not picking on anybody in particular, but I am currently sat on a group with one of our local authorities that is trying to develop culture and a way of moving culture forward, and the view of culture of that group is very white, it's very Anglo-Saxon, it's very middle class, and trying to get that group to realise that not everybody in England comes from that background, and that they will have different ideas about what culture is proving really difficult. And I can honestly say that when I attend that meeting, it's the single meeting I attend where I walk out of the room feeling as if I've not been heard and I've just annoyed everybody by having that view. So we've got a lot of work to do to make everybody feel comfortable. I have attended every single network in the ICB as an organisation, and none of them have left me walking out with her feeling warm and cuddly. We have people who still don't understand what disabilities are, who still don't understand what reasonable adjustments look like. We have members of staff who deliberately do not come to work in a way that they can be identified as stereotypical LGBT, and they still don't realise that the reason why they do that is because they're afraid that they will be identified and bullied. That is not okay. So we've got a lot of work to do.
So are people happy to sign up to us having a consistent approach, which was the question that Patricia put forward? Siobhan?
Yeah, I mean, I fully support it. I mean, for me, looking at this, it's like an interesting baseline. And since I've been at UHD, hearing some of the lived experiences of staff, there is a lot of work to do. And it will take some time, because it is culture. A lot of this is quite deep culture work. But absolutely we'll sign up to a consistent approach. I think that's really, really important. I also wonder, as an ICB, are we creating a sort of proactive anti-racist statement as a board? Because I think it would be a good thing to do if we haven't planned to do it.
So what I would say, if we're going to do that, and I've no problem with doing that, we just need to recognise what the fallout from that will be, because when we did that at DCH, I lost count of the abusive letters I got from members of the public, some of which went to the police and one ended in a prosecution.
Gosh, and do you know, I did that at Whittington Health in North London, and I didn't experience any of that.
Got to the part where
it's partly because of the different environments.
Natalie literally had to filter my
post
posts because on a daily basis there were letters arriving.
It's a really challenging. I mean, I won't bore you with details now, but in the centre, on a daily basis, would get FOIs around how many staff I had with EDI in their title. And constant stuff from the right-wing media. Constant. I mean, it was just a daily thing. So you have to be really clear of the environment that you're walking into if we're going to do it. But let's have that, I think, as a part of a discussion with the people plan overall. I know there's still hands going up, so I've got Ben, Dan, and Manish, and then I'm going to move us on. We're going to have to finish part one a bit later, I'm afraid. So Ben, do you want to go first? Can somebody give him a mic?
I mean, just very briefly, clearly it's interesting, the primary care comment in that report, and I think my ask is I think primary care probably will need some support from the ICB around this, because actually I think we probably are unsighted on it. And quite interestingly, on my email thread this morning from one of the GP rags, 20% of all young GPs reports of experiencing racism in the past 12 months. So, it's there, and I think we probably are unsighted. So I'd welcome a uniform approach, and I also welcome some support from the ICB in primary care.
Yeah, great.
Thanks, Ben.
I can't remember who else said was next. Was it Dawn? Yeah, sorry.
I was going to say I'm very happy to sign up, and I know that the CPAs are already doing some work together on this across the system, and Nicola's engaged with that, so very happy to sign up.
Manish?
I'm kind of conscious that I'm sat here with a Royal Navy Race Diversity Network mug in front of me, so I'll be slightly careful about what I say. Really quickly, firstly, I get where you're coming from, that you were upset about reading the report, and I hear that a lot, especially from senior leadership in the forces across defence. To me, it's not surprising.
No, it's not.
We know this, and I think I guess a couple of words of caution. Firstly, like a few of us have said, you said yourself, we've done a lot of data collection around this. We know. So one of the things that I quite liked was that the report doesn't focus on let's try to understand, let's listen. We've done that, you know, let's move on and do something about it. So thank you for that. Secondly, one of the things you said earlier on was about representing the community that we're from. For me, it's not just about representation. Yes, representation is important, but it's also about genuine meritocracy, equity of opportunity, performance optimization. You know, all of that kind of stuff. It's not just about representation, and especially as you were saying, you know, when you're in a community where actually there's not very many ethnic minorities. Does that mean that we don't need it to have ethnic minority people going through the system? No, it doesn't. You know, so I think we need to be a little bit careful about that representation thing and how much focus we put on that. And the next one is, again, going back to the networks. We need to be really careful about what is and what isn't, or what should be and shouldn't be the role of networks. Because networks are not there to do the organisation's work for them, and there's something there about you know, placing the burden on marginalised people, whether that's disabled, due to sexism, ethnic minorities, to address the roots of their marginalisation. So we need to be really careful about how we do and don't use networks. And completely agree with what was said earlier on about being evidence-based about it. There are good evidence bases for some interventions. There are good evidence bases against some interventions as well. Unfortunately, a lot of those that there is evidence against are the really easy, quick ones that are not in this report. I'm not saying that that's where we're going, but just to be careful about that, and note that diversity, equity and inclusion are all outcomes that they require concrete work to get to those outcomes. I'll stop talking.
Thank you. And just to pick up Ben's point, just to re-emphasise Ben's point about also support for primary care, because that was one of the biggest questions that we got when I was in the national team, and we weren't able to support in the national team because of the complications around primary care. Primary care is properly part of our system, so I think we need to make sure that we do provide that support. Actively just think about what that's going to be. Okay, I'm going to move us on. Sorry.
Sorry, just one sentence. Just the two reports are very pertinent for primary care, and I don't want general practice to get missed in this collective conversation. Thank you.
Really important point. Dan, go on.
Sorry. I just want to clarify, because I support the consistent approach point that Patricia asked us to recommend. We're talking about the whole system, right? So local authorities, not just NHS providers.
Yes.
And I just wanted to clarify that we are talking about
one
Dorset rather than the NHS bit of Dorset.
I'm assuming silence from over there is agreement.
I mean, there'll be some practicalities about how we do it because they don't have the same data, for example, and stuff. But I think we should have a consistent approach. So, okay. So let's move on to reading the signals update, and I have to apologise to Debbie for earlier for saying that the maternity stuff was going to be in part 2 because it's actually in this bit here, isn't it? So I'll take that back. There you go.
No problem. I'll be quick because I know we're behind time. I'll take.
Thanks, Fran.
Thank you. Thanks, Fran. Take the report as read. So the report's coming to the board following the publication of Reading the Signals, the East Kent review into maternity services that was published on the 19th of October. Obviously, this follows up from Ockenden 1 and 2 that were published prior to this. The East Kent report is a pretty hard read. I don't know if anyone hasn't read it, but if you haven't, then have a read of the executive summary. It is quite a hard read though, and it is as damning, if not more damning, than Ockenden, I would say, sort of second time round. So, and we've got other reports coming this year, so hence why we've got a real focus on maternity services nationally, and hence the discussion we had previously around sort of CQC, I think. So the report just sort of sets out what East Kent was about, the fact that its key themes are wrapped around 4 key themes, which are set out in 2.2. And then the report just goes on to identify what we've been doing in Dorset and led by the LM&S across Dorset, both in response to Ockenden first and now in response to East Kent. So each of our providers have done a really good job at actually sort of delivering almost all of the 7 initial essential actions that were required following Ockenden. The subsequent actions that required from the second Ockenden report haven't actually been, the trusts are working on them, but there's been no requirement to actually report against them as yet, because nationally they were waiting for the East Kent report to be published. So NHS England are actually currently developing a framework for a combined reporting framework for Ockenden and East Kent to actually be done from all LM&Ss across the country, and that's going to come out fairly soon. So really the report is for noting. The LM&S is taking really close oversight of improvements and delivery of the recommendations from each of these reports, and actually so are region and national. We have to do a very robust regional return on a monthly basis. So it's there for noting. Happy to take any questions, but it's just to give the board that assurance that we are on this and monitoring it through the LM&S really.
Thank you. And there's a bit more detail to this in part 2 as well, isn't there, on the equity and just a bit.
But yeah.
Okay.
I may have missed this, but what's the time frame for this, Debbie, in the sense of assuring ourselves that the actions have actually been embedded?
Yeah, we haven't got a time frame yet, so we're waiting for NHS England to actually produce the template, which will give us the timescales for delivery for both Ockenden 2 and East Kent. So up to now we've had to deliver the 7 essential actions which we've done, and the trusts have started work on all of the 15 other recommendations, and we started work on this as well. So, but there's no actual timeline yet.
It's frustrating, isn't it? Because you read that East Kent report and you want to immediately get things started and sorted.
And I think in fairness the trusts have.
Yeah,
I mean, I think in fairness we're not waiting for the NHS England template, but what I'm saying is there's no national deadlines yet for reporting or for delivery of A, B or C. And some of the recommendations need national delivery anyway. Some of them are outside the gift of local systems. So it'll come very soon, don't worry. And it'll probably have a really tight timeline then to deliver.
But we've started the work, haven't we?
We've started the work. I'm absolutely happy that we've started the work and that,
Okay, any more questions or comments?
Can I just ask about the key action 2, which is talking about trying to embed compassionate care? I mean, that must be. One can't imagine from this experience of the service that there aren't individuals who wish to offer compassionate care. So I mean, the barriers to that compassionate care must be the things that we're looking for.
I think so. I mean, I think the difficulty with East Kent was it raised significant cultural issues within that organisation. I would like to argue with some real sort of evidence around that actually we've done insight visits, we've done that with NHS England, that there's learning for all, but do we have the same cultural issues in our 2 maternity service providers that they had in East Kent? I would suggest not. Doesn't mean to say there's not some learning, but there was a real cultural issue around and them and us around midwifery and obstetric service, and very much a board that didn't want to listen at all to any concerns that were being raised, and so a real lack of listening to people. So there were some real significant cultural issues that were ignored in East Kent, and that led to really poor care and very sort of a real lack of compassionate care and a real lack of listening to people that produced horrendous outcomes because of it. So you can never say never, but first impressions and visits and that I've done to both of the maternity units haven't got that feel at all, and we certainly didn't get that when we did the insight visit with with the regional colleagues as well. So.
Tricia? There's a question in my mind which I don't think you'll be able to answer, but I think it'll be helpful for us to just hold it and see. well, first of all, I have worked in a unit where midwives and medics didn't talk to each other, and more importantly, medics, as in obstetricians, didn't talk to each other, and believe me, it's horrible. And it does lead to safety issues. But my question is, whilst we might not have any care or compassion issues in general, if we go back to the report that Dawn had, what we do know is nationally, if you're black, you're 5 times more likely to die in childbirth, and your baby is. If you're mixed race, it's 3.5 times. If you're Bangladeshi, it's off the scale. So, do we know if any of that is reflected in our health inequalities data in maternity services? And if it is, I know we've got a plan, but just being clear about what the problem is we're trying to solve with the plan that we've got. Because I honestly don't know if that's reflected in any of our services either. And that's not about skill sets, that's again about understanding cultural needs and making decisions for people and on their behalf that are not valid. So Debbie, are you able to answer that? Do we know?
Well, I think that sort of takes us on to the report that's in part 2, which is our sort of equity and action plan and the analysis and the audit that we did, and so probably bring it back as a response into that thing. So I think it's probably, my response would be that it's work. It looks like we've started. It was done before I started. It was started in May. It has been co-produced with MVPs. It is work that started for maternity services. There's still loads to be done. I mean, it's not going to be a quick thing.
The report in part 2. I'm just interested in trying to understand a bit more about the baseline we're starting.
Yeah. So let's pick it up when we get to part 2 this afternoon. So, thank you very much, Jonathan.
I have a general question about the Oxford report and things like that. So it cited the problem of actually getting the issue raised by the board and things like that. Are you confident that if an issue like that did arise, that we would react to it differently, I suppose, or it would get through to us? That's my concern, or not a concern. It would be something we should be aware of. What are our biases that would stop things? What were the biases in that organisation? Are we displaying them? Is that articulate enough?
I'm sort of too new, I would say, to be able to answer that categorically, and neither of our providers are here, and I think it would probably be Siobhan would need to answer whether... Who's on screen?
Nick.
Oh, Nick's on screen, so Nick could answer that. So it is a good question. I think we've got evidence that we've got system-wide safety culture, we've got SI panels, we've got evidence that they are listened to and they're actioned, and so when things don't go wrong, we've got evidence that learning is really embedded. So I've got evidence that actually that the providers are listening to when things go wrong, and actually I've got a culture of trying to embed that learning. So in that respect, absolutely, there's evidence. I guess I'd lead my colleagues around on that.
There are. You can use as an evidence base, but I think there's something also about being really clear about what happens when systemic failure starts to come as a result of cost savings. So I remember when I first joined DCH, the first board meeting I went to, because the organisation had been in special measures for quite a while, somebody come in to present on the maternity report, and as they were walking out the room mentioned that they hadn't got a single incubator that worked and they were borrowing them. Now, that didn't get raised up to the board level because the habit of the organisation had been, well, we know we've got no money, we're not in special measures because we've got no money, so we just don't tell anybody about anything, we just manage. So I think we've got to be really careful that as we go into the next year where the NHS is going to be very, very financially constrained, that we don't sleepwalk into certain things that we're not aware of.
And it is partly about what type of questions we're asking, but also how we're doing some of that, some of the points that Debbie mentioned. But Nick, you wanted to come in? And Siobhan's back as well. So Siobhan, the question was from Jonathan about the issues that came up in East Kent. Are we confident that our boards, so your board, Nick's board, couldn't display some of the same kind of behaviours, closed ears, or things not being risen?
And Nick obviously will come in, but we've all had our board conversations, so our board have looked at detail at the actions, and actually it's been looked at our quality committee in terms of assurance, and a real assessment of where we are against, obviously Ockenden some time ago, but East Kent. And we've had our insight visit where the feedback was actually very positive, which was good. Nick, do you want to add?
Yeah, I was going to say something similar, Siobhan. We've got the level of assurance, and we've taken this through our boards, and we've had the detailed discussions within the subcommittees as well. And I think we've got a good level of assurance at the moment around it. It's none of our indicators are flashing, and I think that we have got a good culture within the department, but also across the organisation as well. But one of the things that we discussed as a board is absolutely not being complacent, and really making sure that we were keeping an eye out for the canaries in the coal mine, and really sort of trying to identify any kind of areas that might give us cause for early concern amongst all of the noise, which was one of the things that the Ockenden report picked up. So I'm like confident, yes, but not complacent, I think.
Yeah.
Go on.
I was just going to say, although this is specific.
Thank you.
Sorry, thanks, Nick.
Maternity care. Actually, this is an issue that could be any of our services that are less visible than others. And I think there's something about having that really embedded safety culture within the organisations, but also across the system, but also making sure that we've got all of those other safety nets that we use, such as freedom to speak up and things like that, so that we're listening to that soft intelligence that we sometimes don't get through, formal board meetings and governance rules.
It is about culture, isn't it? But it's also about what becomes normalised. And I've seen this play out previously in mental health, where it was just normalised for people die. So people die, and the board actually weren't asking questions then around the death. So there's something about just keeping our antennae sharp also.
There was one other thing that I meant to say, and that was that I have managed to successfully appoint a deputy director for maternity and perinatal services, subject to going through the recruitment processes. But I think that will be really positive, because we'll have a midwife clinical lead within the ICB that can support our directors of midwifery and our maternity services across the system with that independence and fresh eyes. So I know both our directors of midwifery and our CNOs are really pleased about the appointment and really sort of looking forward to working with them. So I think that will give you that independence of being able to visit more regularly and actually sort of have that fresh eyes from the system. I think. So
thank you. And thank you also for digestible paper, because it was a nice good length. So thank you. Okay, so I haven't had anybody ask for the items in consent to be moved into discussion, so she'll take it that people have read it and able to consent. We also don't have any questions from the public, although I think most of the public members have probably gone. We didn't have anything advanced given in advance, so that moves us on to any other business. I'm just going to literally whiz around the table and see if anybody catches my eye that says they want to. There's any other business? Back table? No. Okay. Key messages from the meeting. So I think there were a couple, weren't there? Certainly around the res and the DES discussion that we had, and the international recruitment, where we talked specifically about being consistent in our approach, but also trying to influence the national policy around international recruitment and what we're doing. I think we also had a discussion around influence international policy. I need to learn to capture notes as I'm going along, so I'm going to go to Liz to see what else I've missed in terms of key messages that came out.
I think also in terms of those 2 points, we were talking about a system-wide approach, which we said about consistency and also learning from our partners so that we are a leading organisation on both those fronts.
Yeah.
I think probably
and anything on the earlier bits?
Test and learn.
Yes, that's the key one actually, wasn't it? And our pace around test and learn. Yeah, so thank you. Okay, so our next meeting is on the 2nd of March at 10 o'clock, here again. So that brings us to the close of part 1. So thank you everybody for that. And I'm going to suggest that we break until 1:55. I think some of